Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. The main item on the agenda today is the discussion on end-of-life care in London. However, we have a few short items of business first, and can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. Apologies for absence have been received from Assembly Member Desai.
Thank you. Can we note the list of offices held by Assembly members, and can I also ask members if they have any disclosable pecuniary interests in any specific items listed on today's agenda?
I'm going to die.
Yeah. For the minutes, can we confirm the minutes of the meeting held on the 30th of January 2025?
Yeah.
Thank you. Can we note the completed and outstanding actions arising from the previous meetings?
Noted.
Thank you. And can we note responses received from the Chair of the National Health Service North West London and the Chair of the British Dental Association to the committee's report on dentistry in London?
Noted.
And that brings us today to our main item, and I'd like to extend a warm welcome to our first panel of guests. Joining us to discuss end-of-life care in London, we have Dr. Catherine Buxton, who is a consultant in palliative medicine at Imperial College and the clinical director for palliative and end-of-life care for the Strategic Clinical Network at NHS London, NHS England for London region. Welcome. Sarah Scobie, who is the Deputy Director of Research at the Nuffield Trust, and Dr. Lindsay Williams, who is a GP in Brent, as I found out just before the meeting, and the Clinical Lead for End-of-Life Care for the North West London Integrated Care Board. Before we start, I know it's an emotive subject that could be triggering, so if anyone needs to step out at any point, please do so. And there is support available through the Samaritans as well, as we're aware this is a subject that could trigger emotions, and it is a very emotive and important subject for Londoners. So I would like to start by asking the first question to Sarah, first of all. Just a question about how the landscape of end-of-life care in the UK and in London has evolved in recent years.
Thank you very much, and thank you for having me. So I'm going to be talking really about England and the UK rather than London specifically, because that's the scope of our research. I think one of the first things to note is the shift in place of death that's occurred. So the proportion of people who are dying in hospital has been declining over time. And at the beginning of the pandemic, there was, in particular, a rapid increase in the proportion of people who die at home. So in the latest data, around 28% of people in England and Wales died at home. In 2004, that was only 18%, and in 2019, that was 24%. So there has been this big shift in people dying at home, which will have consequences for the care that community services, GPs, social care services need to provide. I think as well during the pandemic there was a shift in the pattern of care provided by hospices. Hospices tended to increase the hospice at home services that they provided. Many of them reduced the number of inpatient beds that they had, which again is very relevant to the pattern of care needed to be provided. I think it's fair to say, though, that in terms of the landscape, it's very much been evolution in the responses from services. So there hasn't, that I'm aware of, but it may be different in London, been a really proper focus on what these long-term trends mean. And what's needed in terms of service responses. Services will have responded organically, but there hasn't been a sort of major policy shift or shift in funding, for example, that will have underpinned that, certainly at a national level.
So just to probe on that a bit further, so is that hospices adapting to more people wanting to die at home and adapting their services rather than any policy or shifting?
Well, I think it's really important to bear in mind that most people who die get most of their services from general NHS services. So a small proportion of people die in hospital, around 4 or 5%. Many people do have hospice at home services, but it'll often be community nurses supporting people at home, social care services, whether those are funded or organised and paid for. 20% of people die in care homes, so there are going to, there's a lot of social care involved at the end of life. Around 43% of people die in hospital, so general NHS services are very often the teams that are working closely with people at the end of life, and the specialist sector may well be supporting those teams rather than necessarily providing the majority of the care. So it's just important to understand that the specialist end is specialist, and many people get general, generic NHS social care services at the end of life.
And do you expect the current level and type of need for palliative and end-of-life care to change in the near future?
Well, I think, again, just stepping back in terms of the demography, we're expecting in the next 10 years a 13% increase in the number of people dying in the UK. So that alone is going to result in an increase in need for end-of-life care. We're also seeing some shifts in terms of the pattern of death, so more people are dying at older ages, but then there's also at younger ages increases in mortality rates, and in particular in younger ages inequalities in terms of mortality rates. I think in terms of the population in London, it'll be important to think about the wide range of communities living in London and what will happen as those communities age. And so in recent work that we've done, we have looked at socioeconomic and ethnic differences at a national level, and you have a relatively small proportion of people from minority ethnic communities dying, but in London that pattern is likely to be different and likely to change over time, as well as existing communities do get older, and there may then be needs for care which at the moment are not very visible.
Thank you. I'm going to turn to Dr. Buxton first. So what is your understanding of the current need for palliative care and end-of-life care amongst London's population, and do you have any ways of measuring this?
So to pick up from what Sarah was saying around the UK population, if I just start by reflecting a little bit more about where we are in London. So we know that when we think about numbers and projections and what's going to happen in the future, we know that there is a projected increase in people dying at older ages, which means that people will be living at that older age, potentially with multiple comorbidities or multiple conditions for a longer period of time. So I think it's really important to consider that there will be more people living with a higher symptom burden or having a higher palliative care need that we haven't really been able to quantify, but I think is something that is absolutely crucial. I think everything that Sarah said about the demography of London, I think we are quite unique within London, which is something which is really, really important to consider and to dive into. Those inequalities are particularly important for us to understand. But that said, we know that in 23-24, 62% of the deaths that we had in London were over the age of 75. So it's not that we've got a much younger population, so that isn't a challenge for us. It very much is a challenge for us. So we need to make sure that we've thought that through. Thinking just about the place of death again that Sarah was reflecting, what we see when we look at the regional data is that London doesn't fare too well compared to other regions around England. We tend to have a higher rate of deaths in acute hospitals than other regions do, and we tend to have less deaths in care homes than other regions do. The reasons behind that aren't fully understood, but it's definitely something that we need to think about and to understand. We also know within that, just to say that we do have differences between our ICSs as well, and the demographies of our ICSs are different. The population in southwest London, for instance, is really quite different to that in northwest London. So although the challenges are the same, the solutions to the problem may not be the same, if that makes sense. I think what we also know in London is that, again, compared to the other regions, we have a much higher unplanned emergency admission rate in the last 3 months of life. We've got approximately 7% of people have more than 3 emergency admissions in the last 3 months of life. And all the evidence that we have through some of the Marie Curie end-of-life care reports and things tell us that this isn't what patients want, and we hear it from patients on the ground. In my clinical role, obviously, I still have that clinical-facing input with patients and families directly, and it's definitely something that we hear and see, is that people want to be outside of the hospital where absolutely possible. So there's definitely something about that unplanned care, that frequent use of emergency services. Again, we know that all 5 of our ICSs are in the top 10 for call-outs for emergency services towards the end of life, and we know that our ambulance service responds to over 16,000 calls about palliative and end-of-life care patients a year, which is absolutely huge, considering the first and foremost job of the emergency services is quite different. But there's a lot of work being going on with the emergency services and LAS to be able to help them manage palliative and end-of-life care needs in the best possible way.
Thank you, and same question to Dr. Williams, really on your current understanding on the current need on palliative care and end-of-life care and how you measure it.
So as a GP in Brent, up in Wembley, I also have another role with working with North West London ICB. So I work across all 8 of the boroughs, and I've had a very proactive role supporting all 8 of the boroughs. So I see the disparity between the 8 boroughs, let alone across the whole of North West London. We embarked on a review of all adult specialist community palliative care, and it started in 2021. So this has been going on now for 3-4 years. We've had over 150 engagement events with communities, populations, making sure that we're reaching our protected characteristic populations across North West London, and I've personally attended majority of them. Making them face-to-face as well as online, so to ensure that we don't digitally exclude others. And from so during this process, we could see, as my colleagues have already mentioned, we have an ageing population. There is also a challenge with, we touched on it, definitions of what palliative care and palliative care needs are. And there is a complete misunderstanding, not only with members of the public, but also with professionals in health and care, when someone may have palliative care needs and what being palliative and having palliative care needs mean. So I've spent a lot of my engagement over the last 4 years talking about defining the palliative care needs, which happen from the moment you have a condition that is not curable. And that can be something that you will live with for a very long time. It may be something that may not result in the end of your life. You may die of something else. But the moment that you have a condition that's not curable, you then could have palliative care needs. So it's a very hard thing to measure. And the other thing is, your needs are going to vary. You are going to have crisis points. You're going to have change in your social situation. Maybe a relative passes away. Your daughter moves to Australia. You know, everything is changing. You have an infection and you've deteriorated, but then you've hit a plateau. And so, again, people will dip in and out of that palliative care need. But we know that our population are ageing, and we know that they are having more longer-term conditions. And longer-term conditions are ones that we cannot cure. These are where our kidneys are getting older, so we call it chronic kidney disease. It's where our lungs are getting older, so we're going to have lung disease. We're not going to be able to turn back the clock and fix it. Okay, it's impossible to do. So what we need to consider is about quality of care. And we need to talk about, this is your condition, this is how we can help you live better for longer, And these are why we would use the word, you have palliative needs. And it's just never well received whenever the public hear that. So it's hard to define who has palliative care needs. It's hard to then put that on paper because patients don't really want it in their notes. They don't want to be called palliative. They don't want to be on my palliative care register. Even though I tell them this means then that every couple of months I discuss you with the district nurse, social services, community palliative care teams. You get direct access to me. It means that you'll only ever see me, have a care plan with me. They still don't want to be on my palliative care register. So I think that we're trying to understand the need. And of course, you've got your palliative care needs. You've then got the patients that are end of life, which by definition is 12 months of the last of the life of living, but that's very hard to predict. No one has a crystal ball, so good luck with that bit. And then the communities and the specialist palliative care is a very small percentage of our population, but it's still part of that huge piece. So actually, it's very difficult to determine who needs what and the needs of everyone. And we talk about it in the NHS a lot. It's personalisation. It's personalised care. You need time to be able to have these conversations with people. You need time to get to know the patients. You need time to understand what their needs are, to then say, haha, I think that you have these needs and this would be best suited with this service. Or we're going to do this. And how does that sound? You work with them. But it's very hard to do at crisis. It needs to be proactive. It needs to be planned. And so actually, really, it's a step back, and even looking at the number of long-term conditions we have in London, that's where we need to be looking, because we need to be discussing early with those populations, with those communities, that that condition is not curable, and that's all right, because you can live a very long and good life. It's okay that we're not going to totally fix that and get you back to how you were when you were 21, but we can definitely make you feel better and live longer, but we need to talk about it. And so, in North West London, we've spent a lot of time, looking at and talking to our communities and what they want and where they want to die. So we have something called the WISIC dashboard in North West London. It's unique to North West London, and it's a data warehouse, and it's where we can pull codes from all systems of the NHS and social care. And so for me in primary care, we document everything on IT systems and they're coded. And then we pull all those codes in. And so by trying to identify all the patients who have long-term conditions and then right at the end stage of that long-term condition, and if it's been coded properly, then we have a reasonable idea of how many patients would or could have palliative care needs. And so ultimately, in North West London at the moment, with what we've done, we have about a 2 to 3% of our population, which is 2.8 million, that may have palliative care needs. So that gives you an idea of what we are trying to measure and how we're trying to measure it. Nationally, it's always been a 1% of our population is end of life, which is that 12 months at any one time. But if we're trying to say palliative care needs, it's very different from your end-of-life patients in 12 months of living. So if you're trying to capture the palliative care needs, that's much wider. So you'd be looking at about 2 to 3, 4% of the community. Now, that's a lot of the community. And as Dr. Buxton touched on, a lot of them in London are needing that quick last 90 days of life emergency support. Why? Why do they need that? And I think it's because we need to be more proactive earlier on, discussing, defining what we're discussing, making sure everyone understands, and just sort of demystifying what we even mean by palliative care. But we've started to try and count the numbers, but it was just to give you an idea, it's really hard to do. It's really hard to do. And again, looking at numbers of deaths in hospitals and deaths in homes, that doesn't give you an idea of the quality of death at all. They could have a terrible quality of death, but they've died at home. That may be where they wanted to die, but it might not have been a good death. So again, we've got to be so mindful of when we're using. I know we have to use the data we have, the deaths at home, ageing population. We can try a number of admissions in the last 90 days, but maybe those admissions were necessary. Maybe the wheels did fall off in those last 90 days. Maybe the husband of the caring for his wife with dementia, maybe he went and had an awful stroke or a heart attack and got sick in those 90 days. It's so personalised, and that's what personalised care is all about. You need to be able to have the opportunity to understand it more. But the main data is where people are dying, number of admissions in 90 days, and then what we're trying to do in North West London, which is look at palliative needs as a whole. So we're trying to quantify patients that are coded as in that end stage of a long-term condition. So that's new, and it's something that the national team and worked with London. I was lucky to be part of that in 2019, where we developed this recipe for codes. So it is available nationally, and we did some work with Cheshire, and the National End of Life National Clinical Director has not given a nod to what we're doing. And some areas in other areas in the country are doing it, but we are doing it mostly in North West London just because we have this great database.
Just to clarify, so you mentioned the data system you have in North West London, and it's in other parts of the country. Is it in other parts of London?
Yeah, so it's a search. So the search is available, that you can pull all of these codes, these end stage of long-term condition codes from IT systems. You can do that across the whole country, any area in London. And I did work in 2019, and I did work with each of the ICSs and each of the boroughs across North West London, across London, to show them the search and how it could help them identify more of these patients and have more discussions earlier and talk about palliative care needs earlier, should they wish to. So everyone has access to it. It's just whether everyone's using it, everyone has time to use it. And also, so you have these conversations, you then need to have the services to support them in the needs that you've discussed. So you have these great discussions, you identify these needs, but if you don't have services to help them with those needs, and it makes it very difficult to have those discussions then. But yes, everyone has access to the search. It's called the Early Search, and it's available nationally. But in North West London, it's something that we're using, that everyone can access, and we've created a dashboard from it.
Great. I'm going to turn to Sarah Member Best.
Actually, can I just nip in very quickly?
Yeah.
I beg your pardon. WISIC, what's that an acronym
Yes,
for?
I was going to come in and say that. I thought that was going to be your question. So it's Whole Systems Integrated Care, WSIC. And it's a data warehouse that North West London have. And it pulls data from primary care, secondary care, social care, mental health.
Thanks. Good morning, panel. I don't know if you had a chance to look at the London Assembly's last report on this, which was back in 2016, but when we did that work, at that point in time, 8 out of the 33 clinical commissioning groups in London were performing only 8 were performing above the national average. And I think, Catherine, from what you were saying, that is still pretty much reflective of the picture today. At that point, we made a few recommendations to the Mayor. But one of them was that he should champion the issue of end-of-life care at a local level. The other was pushing health and wellbeing boards to include end-of-life care in the health and wellbeing strategies. And the third was the GLA health team should incorporate an end-of-life care review into their health and equality strategy. I could speak to the last one not having taken place, but to your mind, how far have we come on those issues in the last 10 years, or how have those recommendations been addressed or not been addressed? You want to go, Lindsay?
I'm going to jump in because in North West London, we are addressing all of those from our review since 2021. Have we got the answers to them yet? No, but we've just closed our consultation on Monday of last week, so the 24th of Feb. Oh no, this week. No, last week. On our entire review, and included in the review is all the 3 recommendations that were asked of the Mayor from 2016, particularly health inequalities. And we've already set up a working group with patient representatives and with all health and care representatives across North West London to support how we can improve health inequalities in palliative and specialist palliative care needs. So I think for us in North West London, I feel that we have put a significant amount of effort into those recommendations. but particularly engaging with our communities to make sure that we are understanding what those recommendations mean to them. That's the other thing. You know, there's recommendations that come out, but what does that mean to a patient? What do they want to see from that recommendation? So we've done a lot of work there. So I think from a North West London perspective, we have a lot, and we're very happy to share with you our engagement reports, which cover all of those areas as well.
Yeah, thanks. That'd be good because, of course, it's good in North West London, but the point, I think, of doing the review into the GLA health inequality strategy being having that pan-London response. But actually, I'm going to pull my questions out of order because I think you've just started to touch on it. So if we just continue, I was going to ask you, Lindsay, if you could just talk a little bit more about the community-based approach in North West London and that work that you've been doing.
So this piece of work started from when one of our inpatient hospice bedded units, so the inpatient beds of a hospice, just that part of the hospice, were suspended. And it was in 2018-19 that happened. And following that was when there was a big step back going, why did that happen with that particular inpatient unit? And we started to unearth how fragile these services are, but how well needed they are and how important they are to communities. The moment, it was 9 beds out of, a 2.8 million population. We have 57 beds still in North West London for specialist inpatient palliative care. And that was when we locally in Brent started to do a review and talk to our communities. And then from there, the tri-borough, so Central, Westminster, Kensington, Chelsea, then joined us in Brent and said, right, no, this affects us too because there's an overlap with our populations. We all sit on the border of each other and the services all overlap. And then in 2021, North West London appointed me to support with a programme lead specifically on all 8 boroughs. And since then, we've engaged with our communities and we've looked at the national recommendations and ambitions of palliative care and end-of-life care. We started mapping against each of the 8 boroughs. But then actually what we realised is benchmarking just shows where gaps are and then you plug gaps. And actually, we all felt there was a fragility. We'd already lost one section of service. And a couple of others were already wobbly and telling us, I'm not sure if we're going to be okay, actually, particularly post-COVID and during COVID. And so it made us go, maybe we actually need to look at what we need and what we want. And so we then undertook all these multiple engagement events with members of the community, and then we set up a joint, we had 12 members of the public, myself as chair, and some other health and care experts across North West London, and we met weekly for over 40 weeks and ran through each element of what we felt in North West London, what works well, what we can build on, and an unmet need. And through that work, a big unmet need was actually, it touched on care homes. And we now have a commitment, and hopefully the consultation outcome will be in the next couple of weeks, but in the new model that we're recommending, it's actually additional enhanced end-of-life care beds. And these are beds that can sit in care homes, but not necessarily, but in NHS estates, fully NHS funded, but with a regular weekly ward round from specialist palliative care should they need it, to help support with that generalist palliative care needs of those in these enhanced care home settings. And we actually have a model already in Hillingdon. It works really well. So we actually only had to look up the road to see that it's working. And so we're committed to rolling out another 46 of those in North West London. And that was through listening to our population, listening to the lay members, sharing their lived experience, and this gap between them not being able to stay at home. They're in multi-occupancy homes. They're in poor accommodation, and a hospice at home isn't going to help them because they don't have the facilities at home to have the hospice at home setting, they need to go somewhere. They need to be placed somewhere where then their loved ones can visit them. But then they might have too great a need for a care home, or they might be maybe not the suitable age for a care home. They might not want to be in an older people's care home if they're, I don't know, mid-50s, late 50s. And so this is where this idea stemmed from. So this was a co-production, which we'd never done in North West London before, of a service looking at sort of like the down up on what we want and what we think good looks like, rather than what have we got and let's just fill those gaps. And so in the discussions, in the model of care, we've got in hospice at home, because some of our boroughs don't have it, and we recognise that it is a very valuable service and does help those that want to stay at home and have the facilities at home. We want to increase the community specialist palliative care for those that need it, so adding in some extra hours in the day for them. A 24/7 telephone line is another important part of what was discussed. What happens is, even with the best plans and decisions and family saying and loved ones saying, I feel really confident, I understand what's going to happen to my loved one when they're sick, when it happens, it is unpredictable for anyone to know how they're going to feel. And so in that moment, what we are seeing is an increase in emergency service use. So what we are hoping to achieve is a 24/7 telephone line that is available to those known to be palliative, but also those not. So if someone goes, no, I think my relative is dying and is really sick and it is 2 a.m. and I'm just not happy, but I don't know, I'd never discussed it with the GP. I didn't want to talk to the GP about this, but now I do. They have someone to ring. And so we've got this 24 advice line. We've still committed to keeping all of our inpatient specialist palliative care 57 beds that we have open at the moment, but then also the additional 46 enhanced end-of-life care beds. So it's been a 4-year process with significant public engagement, looking at as much data as we can possibly get, but the data is a challenge, and we recognise that. So we are working off a lot of predictions and a lot of projections. We're using the data that we have from the WISIC dashboard to try and identify and make sure that we're going to meet the projected needs of the population. But it's been one of the most incredible journeys that I've been on. I did also lose my own mother during the process of the consultation as well. So I've had lived experience as well. And along with sharing all of that with the patients has been, I feel that the patients feel listened to, and it's been, and we've received some really, really positive feedback from what we've been doing. There's also a big push for more bedded units closer to home. That's a big one. The travel is still the issue. Getting around London transport, that comes up a lot. Car parking comes up a lot, and prices of parking to try and see their loved ones either at a care home, at a hospital. Those discussions, and that's something that we've tried to factor in travel, but it's really hard to do. So that's something that we admit that we are going to work harder on, particularly with those enhanced end-of-life beds, to consider placement of those, because I think that's something that we can influence. But where units are at the moment, where hospitals are at the moment, and specialist palliative care units are, we can't change those positions. But all of this is actually on our website as well. So we have a full engagement report, and we have a You Say We Did, which we have regular check-ins with our members of the public to make sure that they feel like they've been listened to and that we've addressed their questions and queries.
Thank you, Lindsay, and sorry to hear about your mum as well.
Thank you.
I wonder, how will you measure success off the back of that? And secondly, obviously, I know why you would have a 4-year process with the need to collect so much data and evidence to make sure the plan is fit. But particularly looking at scaling up, or if you were going to take this model across London, thinking now, if this works, to replicate this in other places would be taking us to 2030 is probably not where we want to be. So, but also without compromising on data and evidence for the very individual areas of London. So A, how will you measure success? And B, how can we scale up and meet the right marker of doing it quickly, but not losing the individual needs of areas.
So success is quantitative and qualitative. So your quantitative are your numbers, and your qualitative is the information that you receive back from carers, patients going through or receiving service, and impact. So with our quantitative, with the numbers, we are going to be using the WISIC dashboard. We can look at activity of, how many people are being seen by the new services, the enhanced services, but that still doesn't give you the quality idea. But we can see numbers, so we can see that more people, hopefully, are being offered and supported by all of those services. So hopefully activity will increase. What we also will be looking at is activity into other services. So we'll be looking at London ambulance call-outs, we'll be looking at 111 call-outs, we'll be looking at A&E attendances. Again, it's really hard to tell about quality because we don't know if those were the right thing to do, the necessary thing to do or not, but it gives you an idea of, hopefully, if we can try and reduce even a bit of activity there, we're reducing the crisis. We're reducing that crisis point for that family and those looking after them. So we have the data from our hospice sectors. So some hospices are charitable funded partly, and some are NHS fully funded. In North West London, we have 5 hospices. 2 are NHS fully funded, 3 are part charitable, part NHS. So collecting data from them about activity is variable. So actually what we're working on is standardising how they will report and send back to us the data and information. We're actually trying to create a template for them already in their IT systems to make it really simple for them. Because our hospice is part run by charitable sector, part funded, will send it to Hospice UK, but the NHS hospices will send their data to us specifically. So it's a bit bitty, but we have a working group and we committed in North West London that we will build a template where that's it. We are comparing apples with apples and everyone's data is the same. So we can really see, again, that overall we can see the activity. Overall we can see the activity of the person. Because the best thing about the WISIC dashboard is you can track NHS numbers. So we can see the individual's journey through the system. So I'm hoping that will be the best way to do it. Qualitatively, we're looking at how we can get feedback from relatives, from carers, from people in the system. It's really hard to get feedback during someone's palliative and end-of-life care journey. And we have been trying since the closure of the inpatient units, of one of our inpatient units. And it's difficult because the people receiving care are so grateful to get the care that they're getting. And so it's only after an experience, and usually some months to some years after. I had a patient share with me only a couple of weeks ago. Her husband's death was over a year ago, I think. And she said, I've just got more, I've just remembered more of things that were good that happened. And I wanted to share that. I realised, when I was in the meeting, the working groups, that it seemed quite negative, my experience, but actually there was some good. But there also wasn't. And so it's how long you give yourself. And I think that we just need to be reasonable with how we collate qualitative data, how hard we push people for it. We've been told patients don't want to be, or carers don't want to be contacted now. Now's not the right time for them. They're grieving. They don't want to reflect on it yet. And so, a lot of it will come through, complaints. That's where you'll get your negative, but it's really hard to get the qualitative. We've talked with London Network about data, and actually we do, Catherine might want to come in, but we have a commitment to a working group, Pan London now, to look at data and outcome measures, quantitative and qualitative, which we decided only yesterday in a meeting that I was with all the other ICSs and Dr. Catherine Buxton. So I think that this is, great that we're building on good. And you talked about scaling up. Our commitment is that it's going to be a staged scale up in North West London. And we've always said that it can't all happen in a year. But what we have said is within 5 years, we hope to get the new model of care perfectly running. During that time, the entire time, we do meet with London End of Life Board, and we share what we're doing with them. We share across the other ICSs, and we've already shared so much of what we've done, including using the early tool and data collection. And I'm sure Catherine will share some other commitments that we just agreed yesterday, but a lot of it is building on what we're already doing.
Thank you. I just come to you, Sarah, if that's okay. I was looking at the Marie Curie research from November 2024, and one of the things that came up as inadequate was coordination and communication. So I just wondered, from your perspective, how effective is the current collaboration between the NHS, local authorities and stakeholders?
I thought I put it on. Obviously managed to turn it off again as well. Sorry about that. So I think this is something that is a challenge across many aspects of health and social care, and isn't specific to the end of life. I think that in terms of collaboration generally, I think there are a few things that have already been mentioned in terms of how people access services in an emergency. In terms of the local authority social care, one of the general challenges is that there isn't very good visibility of those services, who they're provided to, who's accessing them, which groups of people are asking and getting assessments, and who's getting access to services. So I think there's a lot of potential for that to improve, because there is now a national client level data set which local authorities are collecting, which could over time help to improve some of that. There are some good examples of structured approaches to collaboration. So there's something called the Enhanced Health in Care Homes programme, which has a structured approach to healthcare, primary care for people in care homes, and regular assessments, regular monitoring of medication and prescribing, and we have seen a reduction in emergency admissions and A&E visits of people from care homes over time, which could well be related to some of that programme being effective. So I think there are examples where it can be effective, but there are also lots of challenges. So particularly hospital discharge is extremely challenging in many areas, with it being difficult to identify quickly enough the right support and package of care that a patient needs when they leave hospital. And we know that from data from the OHID, the Office for Healthcare Inequalities and Disparities, possibly, that around 40% of people who die in care homes, the care home is not their permanent place of residence, so they've perhaps moved there from hospital or been there for quite a short period of time. So I think following through patients and some of the work that Lindsay mentioned could be really helpful in understanding actually what's going on in patients' pathways, but there are a lot of challenges. I just wanted to quickly add one thing, Lindsay, to your success factors that might be worth considering, is looking at variation between population groups, because for all of the things that Lindsay mentioned, that will give you an idea of how accessible services are to different groups, and I think that's something that would, I'm sure is being done and would be really valuable to add.
Thanks. And I just wonder, how can the GLA Public Health team and the Mayor's team feed into that stakeholder relationship helpfully? Is there a way they can be helpful?
Yes, I'm not sure I'm the best person to answer that in terms of what relationships already exist, but certainly in terms of data collection, I think thinking about the social care aspect and the social care data collected about people at the end of life. I know the Department of Health and Social Care are starting to use linked data where they're linking some of that social care data to the mortality register to identify patterns of care, and I think that kind of work that I imagine public health teams could lead is going to be really valuable in unpicking what happens at the boundaries between health and social care.
Okay, thank you. And Catherine, if I come to you and ask about the actions we can take to prevent people dying at home entering that crisis. I think we touched on it earlier, where they end up making use of ambulance, A&E, and unplanned hospital admissions. To what extent can we kind of prevent that, or not? I'm sorry, just the mic. Thank you.
Sorry, I told you I'd forget. So there's actually several really, really important things that can be done to try and help prevent those crisis admissions. And I think, as both of my colleagues have mentioned, that planned proactive care and that early identification is so important and is the real key to being able to make a significant difference. Identifying people early allows you to have planned conversations over time, if that makes sense. So it's not everything that's done in one conversation, because obviously these conversations, they are hard. They're not always welcomed by patients or families, and there's a lot of that miscommunication or misunderstanding of language, I think, that Lindsay mentioned at the beginning. So sometimes there's barriers or hurdles that you need to just work with people to gain some trust, overcome, so that you're communicating with each other effectively before you can even begin to discuss what's personal to their healthcare and what their wishes and preferences might be. And so I think there's lots of things there that we could do to help support. But once we've identified someone and we're able to have a conversation and be able to sit down and understand what it is that's important to them, we've talked lots about, place of death, haven't we? But sometimes it's important to understand what it is about the death that they're after, and actually then that can help you identify what the most appropriate place is. So for some people it's not being alone. Maybe we've got huge numbers of population in North West London particularly that live alone, but that is mirrored across the other ICSs. I think North West London's at the top with that one. But there are people who don't want to be at home at the end of life, yet they live at home. And so it's about them feeling safe sometimes, or having somebody around, and that security, and you then work backwards to identify that place. But once we're able to have these conversations and to think about what people want, it's really, really important that we share that information. And we have a system in London called the Universal Care Plan, which is a digital record system that allows you to share personalised and advanced care plans across the London system. So it's accessible by health and social care professionals, by care homes, by specialist palliative care teams, by district nurses, very importantly by our emergency services, so LAS 111, and it means that whomever a person may come into contact with, even if that's 2 o'clock in the morning and they've never happened to meet that person before, there's some accessible information that explains what's happening with their health and social care needs and what conversations have happened with that person, and more importantly what their preferences might be. So it allows people to have that information, because they're not always able to repeat it in an emergency or a crisis. It's very hard to get access to that, and obviously there's certain medical information that is again very hard to glean from anyone but the most seasoned of our patients. So it's really, really crucial that when we identify people and we have these conversations, that the Universal Care Plan is then used and accessed to enable us to share those records. And that's for all of the professionals across London to think about their role within that. So it's not only creating the records or updating the records to make sure they're accurate, but it's also then about remembering and being aware that those records exist and thinking about checking them. So lots and lots of work with emergency departments and sort of front door teams, London ambulance services, to try and remind them to look at these records and to try and build things into digital systems so that it pops up in front of you. We've got a big red banner across the front at Imperial that tells us when a Universal Care Plan is there, so that people can see it and think, oh, I must go and look. So all those digital prompts and triggers that we can use to help. So some of these things are absolutely critical to being able to help try and reduce that unplanned crisis admission. But I think, again, as Lindsay mentioned earlier, having the conversations, documenting the conversations, sharing the conversations, if we then don't have the right services underpinning everything, we hear from the paramedics sometimes that even with the great work and the education and training that's been happening with LAS to try and upskill them in terms of their palliative and end-of-life care knowledge and needs, sometimes they are in a home with a patient who is at the end of life. They can see a brilliant Universal Care Plan saying this patient doesn't want to go to hospital and they want to stay at home, and a family member that wants them to stay at home, but they haven't got a service that can come out to make that patient safe, to allow them to leave. And so the paramedics often get stuck in a really tricky position where they know what they're offering is not what the patient wants, but they haven't got any way of making that patient safe because there isn't another service that's able to come in and take over. I mean, often that's in the middle of the night and we need to get into working hours, but that does happen, and that is difficult across London for a whole variety of different reasons. And I think that's part of the local variation within each ICS is services have developed in different ways, and so we've got different jigsaw puzzles on the ground, if that makes sense. The way the services feed into each other or interconnect with each other is very, very different at local level. Guess that's, yeah, pretty much.
Thank you. Thanks, Chair.
Assembly Member Wilson.
Thank you, Chair, and good morning, panel. Before I ask the question that I've got first listed, I'd just like to pick up on something that Assembly Member Best started to raise about unplanned hospital admissions. Now, I think it's an issue not just in the very end of life, but also in the perhaps year or 2 years leading up to it. Recently been through this with a close family member, and there were a number of admissions to A&E as immediate crisis, and it was necessary to go in, but every time it then has a general kind of knock-on effect on the wider kind of condition that he was in, and there were some occasions where it was avoidable, and there was a team called the Physician Response Unit, which I think was part funded through the air ambulance, and they came, and that avoided the need for admission, which was great because they were able to do the treatment, prescribe whatever needed prescribing, and avoid the cost and grief of going into hospital. But unfortunately, midway through last year, I think the funding for that was cut, particularly in the borough that we're in. I did actually submit a written question to the Mayor asking to find out a bit more information back in September. Haven't had a response to it. So I don't know if I'm really asking you to comment on that, but I just thought this would be an appropriate opportunity to raise the fact that I'd still like that written MQT question responded to at some point. But I don't know if you want to comment on that first as well before I go on to my next question.
So just as you were speaking, it was just, so what I was thinking about then was a very similar service or very similar services that we've got nationally, Marie Curie-led service with the REACT model, which is a sort of a double-pronged, it's a sort of specialist triage within the emergency department to try and identify people who can be turned around really quickly and then passed on to the sort of community arm of specialist response, which is then a sort of more shorter 48, 72-hour transition virtual ward into the ordinary services. So it allows you to have some of that acute responsive treatment, but not necessarily within the hospital, but you've got that additional level of monitoring. So there are lots of really good examples up and down the country of work like that. I think the REACT model particularly has been incredibly successful. And I know that there's work going on in North Central London to pilot something very, very similar to the REACT model, following the loss of the inpatient beds there. So there are definitely models of funding that we're trying out across London to try and understand what else we can do. And I think it's how we put, thinking about the coordination question, it's about how we put these different services together, isn't it? Because we've heard from Lindsay about all the great work in North West London. There's definitely very similar conversations happening in South East London and about how the services all integrate and coordinate. North Central London have taken a slightly different approach with some of the work around the REACT model. But actually, the real answer, maybe the true answer, is that we probably need all of these bits maybe mapped in together so that patients pass around the system, whether it's into a hospital, out of a hospital, into the hospice, back into the community. And so patients move, and they're always held by somebody. There's always someone who is key working or an identified coordinated person where they can call for advice, the 24/7 number. But it's how we hold people. And at the moment, what we hear is that people seem to fall down gaps, the gaps into an acute or the gaps out of an acute or the waiting for the specialist service because primary care is overwhelmed. And it's those gaps that I think are critical to plug. And I think that's similar to...
Okay, moving on, I think, then to Sarah, if I may. Given the financial pressures on hospices and other care providers, what policy interventions or funding reforms do you think would be urgently needed to support quality end-of-life care, please?
So just to set a bit of context, in terms of public expenditure for people in the last year of life, looking at healthcare expenditure, over half of healthcare expenditure is emergency hospital care. So emergency admissions and A&E accounts for around 56% of healthcare expenditure for people in the last year of life. And I think that's the starting point probably for thinking about how resources might be spent differently. So how do we make some of the models which Lindsay and Catherine have referred to work effectively and be made accessible so that there isn't such dependence on the hospital care. I think understanding how hospital beds are used in London by people at the end of life could be a really valuable piece of work. So really looking at how long people are in hospital, are there issues in relation to being discharged, so thinking not just about models that may stop people from needing to go in, but also how long they need to be there for, and what alternative provision might need to be in place, so whether that's more of the kind of care home beds, end-of-life beds. I think in terms of the hospice sector, in terms of the overall expenditure, in terms of public expenditure, it accounts for only around 4% of public expenditure for people in the final year of life. So it's really quite a small part of that overall picture. Just over half of hospice expenditure on services is charitably funded, though. These are all kind of national level figures, and they may vary from place to place. And as Lindsay said, there are some NHS funded hospices as well that won't be included in this data. So I think it's important to bear in mind that even if you consider the charitable part, it's still quite a small part of the picture, which isn't to say that there are some really significant pressures on those services. So many of the of the general cost pressures across the NHS and social care apply to hospices. So energy costs, things that are pay related, so national insurance contributions, those sorts of things are going to potentially have a disproportionate impact on hospices. And what I would suggest is that the kind of work that that Lindsay referred to about mapping out what provision there is in different areas is something that ICBs need to be doing to see where there are gaps and whether they are commissioning the services that are needed by the population, and that in doing that, whether does that need to lead to funding shifts at a local level to be more responsive to the needs of the populations.
Thank you. On a slightly wider point about social care more generally, rather than just specifically end-of-life care, I understand that the government has initiated a commission, but it's not due to report until 2028. Is there a danger that by leaving it so close to the next election, that rather than actually coming up with a broadly acceptable solution that everyone can get behind, it just yet again becomes a political football that doesn't get resolved as we head into election season?
Yes, I think that is definitely the case. I mean, I think that there are a lot of issues to understand and consider as part of a reform plan for social care. So looking at the state of the social care provider market, looking at routes to funding, looking at skill mix of staff, but also in the short term, improving the investment and the certainty that social care providers can have about what funding they're going to get, because very often there are stopgap additional funding that comes quite late, and it makes it very difficult for social care providers. Well, it makes it very difficult for local authorities, but it makes it very difficult for social care providers as well to invest properly in improving services and being able to train and set up new services. I think there needs to be some short-term certainty about funding, as well as more rapid reform than it looks as though we're likely to see at the moment.
Thank you. That's very, very helpful indeed. Thank you. And my final question then, I think primarily towards Dr. Williams, but if anyone else wants to comment afterwards as well. So what do you see as some of the key workforce challenges for professionals working in palliative and end-of-life care, and what changes are needed to ensure that workers can continue to deliver high-quality care?
So we know that for specialist palliative care, there is a workforce challenge. There is not as many specialist palliative care consultants and trainee consultants, specialist palliative care nurses, as there once was. And we can see the demand increasing. We know that we've got an ageing population, so we're making the assumption that there's going to be more need for specialist palliative care. So in North West London, for example, as part of our model of care, we are committing an organisational development workforce support for our specialist palliative care providers. So all the providers, all 5 of them in North West London, we will be supporting them with their organisational development. We'll have a working group with them all together to make sure that there is the importance of clinical leadership is something that needs to be clearly defined and referenced and enforced. Succession planning. Growing your own is a big topic that hospices particularly are very good at doing. They're very good at internally building colleagues up, enhancing their skill set and moving them between areas of service. And I've seen that over the 15 years that I've been working in Brent, but in supporting palliative and end-of-life care. So there's definitely a commitment for more succession planning and more development of colleagues into more specialist palliative care roles. Palliative-wise, palliative care needs, so identification, discussing, so we talk about care plan, discussing someone's preferences, wishes, navigating that, delivering that care. It's in everyone's portfolios, it's always in everyone's programme to do more palliative education. I feel that it's done very light touch and never as much as it should be done, probably not repeated as often as it should be. But we have to remember, for example, that it's a small proportion. You know, if I look at my district nurses in Brent, for example, they'll have a caseload of about 100 patients at one time across the whole borough of Brent that may be in that end of life, in that last 12 months. They're seeing thousands of patients a year. So for them to keep upskilled with recognising a patient that may have palliative care needs, communicating with them in the right way, style, documenting it onto a universal care plan, this is all actually quite difficult to keep up to date with. And it's the same with care home staff, for example, and that's why the enhanced end-of-life care beds are so innovative and novel, is because the model is that you're keeping those care and health professionals in that unit upskilled consistently. So you're making sure that they are ready, enhanced knowledge for those patients that will be coming into those beds. So it's very difficult, but it would be nice to see a little more frequency of palliative care understanding and training. And I think if there's anything that I would really like to see, and Catherine and I feel both very strongly about it, is it's called death literacy. It's the language of palliative specialist and death. In health and care professionals, as I mentioned earlier, everyone has a different understanding of what each of those words mean. There is a unified understanding. In other areas of the country, they have a unified document that says when we're talking about anything to do with death, dying, palliative care needs, use this language. This is what we follow. This is how the process, this is the policies. So we've got that in other areas of the country. It would be lovely to be able to see that for us in London. And it's one of the London region's palliative and end-of-life care strategic network's commitment is to develop death literacy or something similar. That for me, if you get understanding, and that's public facing, that's professional and care facing, then we all stand a bit more chance of being able to talk about it more, of being able to identify it more, of being able to get the people what they need. Because until we do that, we're already on the back foot, and we're trying to achieve something that most people aren't too sure what it is, actually, that we're trying to achieve. So a big part of that, I feel, is death literacy. But I do think that we need more commitment to educational support on a regular basis, and in all of the generalist areas, like primary care, like district nursing, like other community services. You know, as we mentioned, community specialist palliative care is just for that specialist needs, those that are very complicated specialist needs at crisis point for a brief period of time. It's rare that someone would sit under specialist palliative care for their whole journey through palliative care. You actually have touch points with them, but you wouldn't remain under their care the entire time. So we actually need to make sure that everyone else in the system understands, and in the population understands. I think there's more nationally that we can do public facing. But that's, they're my big opportunity and of areas of workforce is knowledge, is giving them a resource that they can use, and just making sure that people have the time to be able to do the learning. That, you know, this has come up in a North West London Staff Away Day last week that I was at. No one has time to consider personal and professional development. In the health and care system, everyone is firefighting, is just working, and it's because they all care about what they do. They care about their patients so much. They need time penciled in to be able to sit back and go, right, what are my developmental needs? What am I missing? What do I need help with? Because it's all well and good me sitting here going, this is what we should do, but actually they should be able to tell me what they need. And a lot of the time they don't get the chance to, they don't get the time to.
Thank you. So my next question is for Dr. Buxton first. So what is the extent of unmet need for palliative care and end-of-life care in London, and also you can speak from the UK perspective, and are there any particular demographics or communities that are missing out on this care?
So the short answer, I guess, is yes. There is lots of inequalities in palliative care, unfortunately, across London, and I think with the complex population that we have, I think it probably is maybe more of an issue in London than in other areas. So we know that the inequities and inequalities surround many, many things. So we've got inequities around age and around diagnosis. We know that our white British population with cancer tends to be much more likely to have access to specialist palliative care services than other ethnic populations or other diagnoses. The reasons for those are complex and not fully explored, so there's definitely a lot more work that needs to be done to try and understand that, and I think understand things from an individual need point of view, because we really need to be managing and supporting patients' individual needs. But there's also much more work to be done around the different populations and ethnicities, religions and cultures that we have across London. There's definitely been specific projects specifically outreaching into local areas. There's been lots of work with the Bangladeshi population, for instance, down in southeast London, which has been fantastic. And it's about how we pull out and understand some of those common themes, I think, at a higher level, that we can think about whether that way of working or that way of approach is going to work with other populations as well. So it's trying to think about how we can do that and how we can understand the needs in the best possible way. We've also got inequalities around socio-economic status. We've got huge areas of poverty, obviously, within London, which is then contrasted by much more affluent areas. Again, affluence is associated with being much more likely to access specialist palliative care services than those in poverty. But we also know that it's affecting patients being able to stay in their own home, for instance, being able to afford the electricity that allows them to plug in their hospital bed and their air mattress when they've got electricity meters that are just eating up costs. So there's lots of things around that which again affect the ability to provide good palliative and end-of-life care for people when we do know them. I think, as we've already mentioned, we have some of the geographical variation between our ICSs, but some of these reasons that I've mentioned are reasons behind some of those inequalities and in access, and that's why it's so hard to be able to look at it entirely at a regional level. It's trying to understand the themes, but then to allow enough flexibility so that you can really develop something that meets a local need, and it's about just how that's brought together. There's other work around learning disabilities and mental illness, homelessness, people in prisons. You know, I could go on. There's lots and lots and lots of inequalities around palliative and end-of-life care that we need to understand better in order to be able to help solve them.
Thank you. And Dr. Williams, do you have anything to add from a sort of North West London perspective on that?
Just that we have been delving deeper into those particular, so those from protected characteristics, those from particular ethnic backgrounds, religions, and so as part of our organisational development commitment, we're including cultural competency as part of a standard. Everyone has to develop a cultural competency framework and understand what that means. So everyone that will be delivering, so an organisational provider that is delivering a specialist palliative care service must have a cultural competency understanding. Of course, that's only going to touch on the cultural parts. But what we have already started doing is working closer with faith leaders. So those from Muslim communities and black faith leaders, for example, in Brent. I did a session recently in Harlesden and Willesden. And a big part of it is actually getting the community champions and advocacy for themselves to be able to advocate. A big part is language as well. And also remember the understanding and meaning of death and how what we do in one's end of life and how we manage that end of life and how we talk about death is very personal, but also is very unique to each culture, ethnicity, religion. And so we need to make sure that each service understands. So there's an element of understanding from the services. Because I'm always stand by this, it's what can we do better? We need to reach the population. Everyone says, oh, they're the hard to reach. No, they're the need to reach. We need to reach them. We need to figure out how our services can be more accessible. And we have to remember as well, a lot of our hospices are St. John's, St. Royal Trinity. They have a very religious connotation to them, which immediately puts people off going to them as well. So, there's a part of the history, the historics that we may not be able to change. But if we know about it, as Dr. Buxton said, I think that there's that understanding and then sharing, this is what we know, this is what we've heard. Are you hearing the same? Okay, great. Then let's make sure that everyone knows that this is happening. And it gives everyone at least a half chance to change, develop, improve their services. I know some of our local hospices of Royal Trinity did an open day recently to local faith leaders from different faiths, and it was very successful to give people a chance to look around the hospice and see what it was like, and really demystified a lot of what hospice care looks like. So I think that there's more. So we know, and we've committed to improving cultural competencies, and we've got a commitment with each protected characteristic and how we are hopefully going to improve, make sure our services are more accessible. But I think that a more regional support of understanding would be very welcomed.
Thank you. Thank you. Assembly Member Boff.
Dr. Buxton, how might the assisted dying bill impact the delivery of palliative and end-of-life care in London?
So, being a NHSE member and being the hat I'm here, I'm going to half answer your question. So, what we know is that the legislation is obviously up for discussion. We don't know exactly what that legislation is going to look like. But obviously, as the networks, we are committed to working with regional teams to help deliver and implement whatever is required. But whilst we're doing that, we will obviously look to maintain and grow and absolutely continue to do what we're planning and thinking of doing around palliative and end-of-life care services.
Do you see a situation where people in your profession would add assisted dying to those menu of choices that people have at the end of their lives?
Thinking about it purely without my NHSE hat, I think the honest answer is it's really difficult to say. And I think there are a lot of very mixed personal and professional opinions that we all have and hold. And exactly how I think that's going to end up being delivered and implemented, I think is a really challenging question. And I think we all, given the limited workforce and the resource that we've all talked about today, have concerns about how that fits into what we need to continue absolutely delivering. But actually, more importantly, we've heard about all the work that we're planning for the future that we need to deliver, the new work, and we want to make sure that we're able and focused to be able to continue doing what we know needs doing, rather than having to divert what precious resources there are into other things, and that balance is going to be a real challenge, I think.
Thank you. Ms. Scobie, do you indicate?
Yes, thank you. The Nuffield Trust is undertaking a research project at the moment to look at international evidence about the impact on health and care services of assisted dying being legalised. We're partway through that project, but I think that there are a couple of immediate thoughts that I have from that work that are relevant to this question, that definitely don't answer it. These are very, very big, difficult questions, and I think that one of the things that we need to bear in mind is that we don't really know exactly what model might become legal, if any. And certainly internationally there are a number of different approaches in terms of the extent to which assisted dying is integrated with health services, separate, how it's organised. So I think that there are a lot of uncertainties. But I think what I would say is that even in countries which have made assisted dying legal, and where it's been legal and established for some time, the proportion of deaths that are assisted deaths is small. So I think around 5% is the greatest. So in terms of the impact on end-of-life care services, many of those assisted deaths will be people who will have received palliative care services. That's what the evidence tells us from other countries, and the vast majority of people will be needing the support from end-of-life care services. So I think the rationale for continuing to develop palliative and end-of-life care services for Londoners is needs to continue, and I think it'll be some time before we really understand if indeed the assisted dying does become legal here, what the impact of that is.
Thank you. It's an area where if you haven't got cognitive dissonance on the issue, then you're not really thinking about it. So I understand how difficult that question is. Thank you. What further action would you like to see from the Mayor, local councils or government to ensure high quality, accessible palliative and end-of-life care for all in London? Anyone? Go on. Give us some nuggets rather than a treatise.
For me, I think a big part of everything in the NHS is funding. And as we heard, we have an unmet need for palliative care already in Northwest London. We know in London, nationally, we have a growing ageing population, patients with multiple conditions, who are only going to need more care, and that means more care in those final stages of their life as well. We've talked about all of the improvements that we feel are necessary. We've talked about improvements that we in North West London are committed to. All of that needs money and all of that needs funding. And so we need to make sure that we can continue to fund palliative end of care and end of life care and specialist palliative care. But in relation to that expected increased demand, we know that it's going to go up. How much? I'm not entirely sure. I mean, in North West London, I have a stat that I've got a third of an increase in those who are going to be over 65 in the next handful of years. A third increase, 30% increase. It's a huge number of patients.
So that's funding, but and any time you talk about the NHS, it's funding is kind of given. What would you specifically perhaps like to see the Mayor to do? Because we're going to have a write-up from this investigation. What would you like to see the Mayor doing with regard to this?
I think raising awareness of end-of-life and palliative care needs, recognising the difference in what each of those definitions are. So more of a common language used, like the death literacy. I think that we need to make it more common to talk about across all of our various cultures and communities. I think we need to work harder at reaching them all.
It's hard work, isn't it? I was on the investigation we did previous investigation that the Assembly did some years ago, and that came up very strongly from there, is people don't talk about the end of their own lives or their loved ones' lives. It's a cultural thing, and unfortunately culture you don't fix in a fortnight. You know, it's a long-term thing.
I know.
Ms Scobie, are there any particular thing that you would want to see the Mayor doing or councils doing?
So I think a couple of things that spring to mind. So one is thinking about social care needs at the end of life. So in terms of thinking about needs for social care, explicitly thinking about people who are at the end of life, and many of the points about training, for example, would apply to the social care workforce as well as to the healthcare workforce. And then also in terms of the Mayor's work on poverty, thinking about benefits uptake, there are a number of benefits that people can get fast-tracked, special rules at the end of life. There's a lot potentially that perhaps the Mayor's office could do around making that more well-known and improving uptake.
Thank you. And Dr. Buxton, is there anything in conclusion?
So I think just reflecting both what Lindsay and Sarah have said, I think there's something about some of the normalising conversations about wills, about lasting power of attorneys, about the death literacy, about understanding what the end of life might hold and trying to demystify it, that needs to be held outside of the NHS. The NHS and health can't do it all, and actually something that's public facing that supports what we're doing within health and social care would be incredibly beneficial. When I mentioned the universal care plan earlier on, I didn't add at the end that we have the universal care plan is at the moment accessible as a read-only portal via the NHS app, so every Londoner, including yourselves if you wanted to look, if you live in London, within the NHS app will be able to access a universal care plan. At the moment it's read-only, but the development and the specification to make that so that patients can create and edit their own universal care plans is due to go live this year. So that's something really tangible and really helpful that supports all this death literacy, this earlier identification, empowering people to know that they can take some control and onus of emphasis around their own health and social care, and that they can approach health and social care professionals and create their own plan and start those conversations themselves if they want to as well. So
Sounds
something
like,
really tangible around that would be my
sounds like that's really worth shouting about. In fact, I'll go on the app after this meeting, I think, and see what's there. Thank you very much indeed for those contributions.
Thank you, and we are now at the end of our questions for our first panel. So can I thank our guests for attending and for their answers to our questions. We will now take a 10-minute adjournment break before we welcome our second panel of guests. Welcome back to the Health Committee and welcome to our second panel of guests. We have Becca Trower, who is the Joint CEO and Clinical Director of St Raphael's Hospice. We have Dr. Amrita Jamali, who is a consultant in palliative medicine and at the Royal Marsden and Royal Brompton Hospitals. Ruth Driscoll, who is the Associate Director for Policy and Public Affairs at Marie Curie. And Dr. Libby Solno, who is the Associate Professor and Head of Marie Curie Palliative Care and Research Department at UCL. Welcome all to our panel. I think some of you have been tuning into our first part of the meeting as well, so hopefully you know about the format and how it works. So the first question is from me, it's to Ruth. The provision of end-of-life care in London, how does it compare in London to other parts of the UK?
Well, thanks for inviting me to come along today. The first thing I would say is it's actually very difficult to do definitive comparisons of one place with another. You've probably heard from the witnesses who spoke to you before us that there are different measures in play when you're thinking about population need for this care. There's also no clear approach nationally to matching that need to service provision. So there is no clear picture of what the needs are, no clear approach to defining those needs nationally, and there's also no clear picture of whether services are sufficient to meet that need. That's a really important thing to note before I start, but it is possible to draw some comparisons between London and the rest of England, and Catherine Buxton has already begun to allude to some of them. The first differences that jump out when you look at London relative to other places are in how people are accessing care in London. So when you ask people where they would like to be at the end of their life, most people's preferred place of care is at home. But in London, what's happening is that a much higher than average proportion of people are dying in hospital. So 48.8% of people died in a hospital in London, and that's higher than the England average of 42.8%. The second question that you've also had a little bit of discussion around already is some people, hospital is obviously the right place of care at the end of their lives, but some of those hospital admissions are quite likely to be avoidable. And in particular, emergency hospital admissions are sometimes avoidable. So we're concerned about avoidable hospital admissions. 7% of all the people who died in London had more than 3 emergency admissions in the last 3 months of their life. And 62% of all people who died in London had 1 emergency admission in the last at the end of their life. So emergency admissions are really high in London, and often emergency admissions are a sign that people are in a bit of a crisis. The next thing to mention is use of other emergency services as well. So Catherine mentioned that all the London ICS geographies are currently in the top 10 areas in England for having the highest out-of-hours emergency department attendance for people in the last years of their lives. London Ambulance Service is actually the busiest ambulance service in England, and they're responding to over 16,000 calls from people at the end of life each year. So it's very clear that London has quite heavy use of hospitals as a place of care. Some of those admissions are potentially avoidable. They're emergency admissions. People are coming into A&E and they're having to use ambulances. And the reasons why this is are complex and not fully clear, but there are certain things about the population in London which give us an idea of what the reasons might be for this. And in looking at some of those reasons, what I would say, and you will all be aware of this as representatives of London, London is a big city of contrasts, and those contrasts are part of the reasons why people are struggling to access really good quality palliative and end-of-life care. The first point to make is that there are large numbers of people living in poverty in London. So 24% of Londoners are living in poverty. This is a really huge number. It's around 2.2 million people, and it's nearly double the total population of Birmingham, just to give you a sense of just how many people are living in poverty in London. There are obviously big variations within that. So if we look at the index of multiple deprivation, Barking and Dagenham and Richmond upon Thames were ranked as the most and least deprived boroughs relative to other boroughs in London. But why does poverty matter at the end of your life? Well, on a really basic level, if you're living in poverty, you're not going to have a very good quality home. So housing costs are really high in London. And if your home is not very good quality, if it's cold or damp or small or overcrowded, it's going to be quite difficult for healthcare professionals to come into that home and give you care in a really safe way at the end of your life. So that might be one of the reasons why people are entering a bit of a crisis, having to use emergency and hospital services instead. The second thing to note about London is there's large numbers of single-person households in London. And if you live alone, you're often not benefiting from unpaid care from a family member at the end of your life. And if you don't have someone, a loved one, who's able to give you that sort of hands-on care and act as a bit of a coordinator of that care for you, you're also much more likely to enter into a bit of a crisis as your condition progresses if you've got a terminal illness. Again, there's big variation within London. So again, looking at it from a borough point of view, you've got 51% of households a single person in the City of London versus 22.1% in Harrow. So there's big variation in where those single person households are and which of them have pensioners in as well, because obviously pensioners are tend to be more in need of palliative and end-of-life care. The other thing that I would draw your attention to about palliative and end-of-life care in London is there are certain groups that we know from wider research tend to miss out on really good quality palliative and end-of-life care. Just to give you two examples of those groups who are well represented in the London population, one of them is homeless people. So you will know there's a massive challenge around homelessness in London. It's really at the centre of the nation's homelessness crisis. So the number of people sleeping rough has tripled since 2008 and 9. There were nearly 12,000 people sleeping rough on the streets of London this year. And homeless people often have quite complex health situations. They're more likely to die young. They're more likely to have lots of complex health conditions. They're one of the groups that could really, really benefit from access to really good quality palliative care, but getting that care to them is incredibly challenging. We've been doing some work at Marie Curie to work with homelessness charities and with other providers of homelessness services to help get that care to people who need it. But homeless people are a big group in London who are missing out. The other group that I would mention is black and minority ethnic people. There's very strong evidence that they tend to access specialist palliative care both later and less than other groups. And we know that in London, so poverty might be part of the story behind that. Black and minority ethnic Londoners are significantly more likely to be in poverty than white Londoners. So 34% of them are in poverty, compared with 17% of white Londoners. So they are overrepresented in that group of people living in poverty. Just to give you an example of how that might play out. So if you live in a deprived area, you're currently 33% more likely to have an A&E admission in the last year of your life. So it's a really big inequality in access to care, being a person who lives in poverty. But there are other issues around black and minority ethnic people accessing really good quality palliative care. They tend to have lower access to services, And some of the reasons that have been raised for why that might be are lack of cultural sensitivity among some of the healthcare providers. Sometimes English is their second language, so there are language barriers. There may not always be interpreting services readily and easily available. Sometimes there are people perceive that there are conflicting values between their family's values or their religious or faith values and the idea of palliative care. So there are lots of reasons why this group are also struggling to access this care in London and also nationally. The other thing just to say is people often chat about London being a really youthful population, and that is true, as you know. It's younger than other parts of the country, our population, but there's really significant variation in that within London. So in the inner London boroughs, the population is very young, as you probably know, but in the outer London boroughs, there are lots of older people, and so there is a big need for palliative and end-of-life care amongst those older people. That's still true of London, even though you have a very young population overall. So those are the things that I would pull out about London versus the rest of the country.
Thank you for that comprehensive answer as well. I'm going to turn to Assembly Member Best.
Thank you. Ruth, I was going to come back to you straight away, if that's okay, and ask what improvements are needed in coordination between NHS services, hospices and social care providers to ensure that high quality care for patients.
Yeah, I really welcome this question, so thank you. Marie Curie recently funded the largest nationally representative survey of quality of palliative care in almost a decade. And the survey was an independent piece of research. It was carried out by a team of expert academics led by King's College London, Cicely Saunders Institute, but also including Hull York Medical School and the University of Cambridge. And the survey painted a really bleak picture of poorly joined up services for people at the end of life. So one of the really clear findings from that survey was that patients and carers are suffering because communication and coordination across services are poor. So this was a national survey. Unfortunately, it's not possible for us to pull out the findings for London in particular, but what I would say is we had the highest representation of respondents from London and the South East. So we had a higher proportion of the population responding from London and the South East. So we can be reasonably confident that it's an accurate picture in London as well. So what comes through really clearly is that most end-of-life care occurs in the community currently. So 64% of people were telling us that they spent most of the last months of their life in a private home. 24% of them were saying I was in a care home, and only 7% were reporting being in a hospital. So slightly different picture to what you've got in London. But let's talk about some of the experiences that they were reporting, because I find them very upsetting, and I think you will too. And it's really important, I think, for us to hear the voice of people at the end of life and their loved ones. So this was a survey of bereaved carers. So Lindsay talked about the challenges of trying to ask them to share these views. They very generously shared their experiences into this survey, and they talked about the value of sharing their perspectives with people like yourselves who have the power to change things. So I will conscientiously tell you what they told us. So first of all, they were reporting big difficulties in accessing health and care professionals. They felt that when they could get access to these professionals, they did listen and provide sufficient help. But there was a lack of communication because the professionals just didn't have enough time to have those conversations with them. And I know you've talked about some of the workforce challenges already. They also described quite big barriers in accessing palliative care medicines, especially out of hours. So at nights and weekends, they were describing not being able to find a community pharmacy that was open, or not being able to find someone who was able to prescribe these strong medicines to them, who was qualified and trained to prescribe those medicines at nights and weekends and bank holidays. less than half of them said that they felt they had a professional person who was in charge of coordinating their care. So some of the witnesses you've already heard from talked about the importance of someone helping them navigate this complex system. What was coming through very clearly is the theory is that early, if you get a terminal illness, you will have an early conversation with someone like Lindsay, your local GP, and they will put you on the palliative care register and help you get the kind of support that you need. But what was coming through very clearly was that that recognition of people having palliative care needs was coming way too late. So a really shocking statistic from the survey is that healthcare professionals had discussed death and dying with just 1 in 3 of the people who died. So only 1 in 3 of them had had an honest conversation about the fact that they had a terminal condition. They were also reporting particular problems around getting time with their GPs. So when they got time with their GPs, they were amazing. But nearly 1 in 5 of those who died had had no contact at all with a GP in the last 3 months of their life, which was a really striking fact to us. And as I've already talked about, they reported really high use of emergency services. So 61% of those who died had used an ambulance and 53% had visited A&E at least once. So that's kind of the current challenges in coordination feel for patients and their bereaved carers. And yeah, it's just a really shocking and compelling picture. What I would say is that in London, there's really good work underway already to try and tackle some of these challenges. And you've heard some of the examples of that. Just to give, so for example, the universal care plans in London, amazing idea that you can share electronic health records across all the different providers involved in a person's care is work in progress, still more work to be done. It would be great, as Catherine said, if people are able to take ownership of those through an app. If all the professionals can not just read them but also add to them. There's also work underway to make these records more accessible to social care providers and care homes. So that's a really exciting and important piece of work that isn't happening in lots of other parts of the country. Another example I would draw your attention to is the work that Macmillan have done with the London Ambulance Service. This is a lovely concrete example. So since 2018, they've been providing specialist training to ambulance control room staff, to paramedics and to volunteers who work in the London Ambulance Service. They've got this dedicated team that does that training, but also helps those paramedics to develop service pathways, so connections into brilliant local hospices like St Raphael's. You've got Rebecca here today. So making that connection from the emergency situation into the local services. And there's really, really brilliant results coming through from that work. So the staff are reporting that they're more confident in being able to support patients at the end of life. There's been an increase in ambulance service use of those universal care plans, which often include someone's advanced care plan, so gets them full sight of someone's needs and wishes and preferences that they want at the end of their life. And also there's been there's been a big decrease in the number of ambulance conveyances into A&E over that period since that work began. So really amazing work already happening in London to address this challenge of coordination and more work needed. And the other thing I would say is part of the challenge in getting this coordination right is there's a lack of funding for new ways of working in England as a whole. So sometimes commissioning of services has been understandably quite cautious, and it's been focused on trying to deal with firefighting situations where you've got massive demand, you've got precarious provision. For example, the heavy reliance on charitable fundraising means it's really hard for hospices to meet rising demands. So you've got this rising demand, this precarious funding for services, and that that situation can make it quite tricky to try new and exciting and innovative ways of doing integrated working, of joining up these services in new ways. But the two examples of what's happening, a little bit in London, in big ways in some other places, that could, I think, make a really amazing difference in London. So one is having these 24/7 single point of access phone lines for people who have palliative care needs. So, for example, there's one in Cambridge and Peterborough where if you ring 111 in Cambridge and Peterborough, and everybody rings 111, if you're an end-of-life patient, you get immediately connected into this local hub where there's a palliative care nurse on the phone for you to speak to, who's able to really quickly and efficiently connect you to local services. So that has massively increased access to specialist palliative care for groups in deprived areas who previously didn't get good access and so weren't getting access to those specialist services very well. It's really coordinated the services, and other similar examples exist in other parts of the country. This has been a recommendation of NICE for more than a decade, that these should exist in every part of the country. It would be amazing if they existed in every part of London. The other example I would draw your attention to is the REACT model that's already been mentioned. So in Bradford Royal Infirmary, it's a similar population to London in the sense high levels of deprivation, very diverse population. They had a big problem with a lot of people coming into A&E. They were unable to get them out into services in the community, so they were ending up with unplanned and quite long hospital stays. What they've done in Bradford is they've put palliative care consultants into A&E. Those people are identifying and triaging and asking those people if they want and working out whether they need to be in A&E and hospital. If the person's preference is to be at home and home can be a safe place of care, they're supporting them to transition into those services by providing a step down and out of hospital. And the way that works is they get connected to a multidisciplinary team that includes local hospices who will look after them for this temporary period until they can be transitioned properly back into good community services that are safe and that meet their needs. It's a really creative approach. It's massively reduced the number of hospital bed days. It's actually cut them in half over the period in Bradford. So massively impactful intervention, and it would be amazing to get that off the ground in perhaps some of the big hospitals in London. So I hope that gives you an idea both of the challenges and of the solutions.
Yeah, very much so. Thank you. And actually, just to come back to one of the solutions around the contact line, because I thought that was one of the striking bits in the piece of research around under 50% of people having access to a key contact. And to me, that kind of just stunk of that will lead to people going to the wrong door, as it were. And a lot of those additional A&E visits, as it were. So I guess, but the question for me was, but who is that key contact that it should be, right? So is that with the helpline, who is that key contact? I don't know if anyone else on the panel or Ruth, you want to answer.
This might be better answered by some of the clinical colleagues on the panel. I know that it's a theoretical concept that doesn't always happen for everyone, but you can chat about how it happens in practice. Who coordinates their care?
So if patients are referred to the hospice, then we are the key contact for them. So we do have a 24-hour helpline, and so we would be the coordinator for that, although we're not the key clinicians, because with the patients at home, they're still under the community.
But I'd say, should that be the case? Should you be the key contact? Who should be the key contact in an ideal world?
I think that's a really good question. I think probably quite difficult to pin down, because there are so many people involved in somebody's care at the end of life, and it's difficult to know who should be the key contact. But I guess in terms of efficiency, when a patient phones up, they don't want to be put through one person to another person to another person. So I think sort of certainly in terms of people having questions about do they need to go to hospital, they need some pain control, who is the carer, then we are in a good position to be able to provide that. I mean, I think ideally what we would like across the board is that really, really good coordination of services, because we know that the majority of complaints that we get are around not knowing who to contact, who is in charge, who is going to take that role forward. I think whoever that person is or wherever that contact is, they need to have some clinical expertise to be able to know which direction to sort of move that towards.
I think so. I'm an academic, but also a community palliative care specialist doctor. So work in Camden and Islington, out and about. And one of the key thing I think about who needs to hold this is it has to be the GP, because we're looking at things that have to cut across everyone and ensure full equity. So in terms of generally who is holding that in the community, the GP will always be the person who's holding that case. The key thing is that they don't necessarily have the information or specialist knowledge to then make those decisions. So often you get into one-on-one, the GP panics, they don't know the patient, and then you go into A&E. So whilst the GP needs to be the final kind of point of contact and holding that care, you then need to make sure that there's specialist palliative care advice available 24 hours a day. And in the daytime, 9 to 5, Monday to Friday, that's easier because there are funded services. And so each locality will know who to call. It can be complicated, but there is a number. The challenge is on weekends and out of hours and overnight, which is obviously the large proportion of that week. And at the moment, it's a kind of real mismatch. So when I see someone at home, we've got 3 different telephone numbers to call between 9 a.m. and 5 p.m, 5 p.m. and 8 p.m, 8 p.m, and then the next morning till 8 a.m. Between 8 and 9, there's no one to call, and 9 again, it resumes again. So we've made a kind of magnetic thing to stick on people's fridges because it is so complicated. And one of our main complaints from patients and from ambulance services and from GPs is they don't know who to call. And so they're trying to call the wrong advice line because they're out of hours of that one. And so it's a real mismatch. So the challenge is the GP has to be the final key person in the community, but there needs to be key specialist palliative care input, and that has to be really one number over the whole 24-hour period, who then, like the one-on-one example, you get put through to one number, and that number then, if it's during the daytime, sends you to your palliative care service. You might be in a hospice if you're in that area, or in an NHS team, or overnight to a holding line. We've got one that runs through NCL overnight. So the challenge is not so much who's doing it, it's having that first front door entrance into it, and then once you're into that person can then say, oh right, you're known to St Raphael's, great, we'll link you in, they're open there. So it's that bit's the key.
Yeah, quite, because I mean key contact is probably misleading, because obviously it can't be a key one named individual, because situations even in a day would last 16, 17 hours. So but yeah, like you say, it's about that, what is the front door of my coordinate. Amita, if I could turn to you, just wondered on your take on the transition from CCGs to ICBs when it comes to end-of-life care. Is there any success or kind of concerns you'd have with that?
Hi, you can hear me now. So I think obviously I'm a hospital-based doctor. I work across the Mars and the Brompton hospitals. I think I had to put this question to our complex discharge team who deal with ICBs a lot. And I think, interestingly, both hospitals are in quite a unique position because we are tertiary specialist centres. So, as you know, the Marsden's a cancer specialist centre and the Brompton is a heart and lung specialist centre. So actually we work with ICBs across London because we have patients from all over London and beyond. So I suppose we get a slightly different perspective. And I think the feedback from my colleagues who work closely with ICBs is that I think they said initially at the transition they felt that actually the processes were more streamlined and unified, and it made the process easier. And interestingly, during COVID, before that, they'd found that actually when there was London became unified in the process of when we are thinking about people's care needs, social needs at discharge, when that process was really unified and simplified, it made the movement of patients from hospital to home to other services much more straightforward and streamlined and efficient. What our complex discharge team tell me is that now they're finding that as time goes on with ICBs, there is much more, again, of different processes happening, different policies and individual kind of pathways. So as kind of an organisation where we're working with lots of ICBs, what we're finding is we're having to really look at what individual ICBs are providing and use different forms, different pathways. We don't know what care provisions are available particularly, so we have to look at each individual case. And I completely understand that the whole point of ICBs is that they're looking at their local communities and commissioning services for those needs. But at the same time, when we're talking about palliative and end-of-life care, there are really basic services that we need for our patients that need to be unified across the board, and accessing those and being able to, request those needs to be unified and simplified so that we can get, so that services can be streamlined and efficient. So that's the feedback I've had. Just to give you a really simple example, a very simple thing, like for end-of-life care, most of our patients will need a hospital bed at home to make sure they can be nursed and cared for safely at home. And, we have one particular borough where we're now told that actually if we're sending a patient home to die within weeks or days, we cannot order the bed directly. The district nurse has to go out when the patient goes home to assess the need for a hospital bed. Now, I cannot send a dying patient home without a hospital bed who is bedbound and, needs a specialist mattress. So that then needs to be escalated through the ICB before we get resolution. So you can just see the inefficiencies from our point of view in hospitals of sometimes just making sure that we get the basics in for patients. And obviously this isn't across the board. I can tell you that, there's many people doing lots and lots of amazing work, but these are the inefficiencies we're seeing and the difficulties.
Yeah, thanks. I've heard the thing about hospital beds turning up too late and things like that. So I can imagine that's a big problem. Just if I could ask quickly, it sounded like from what you were saying, Amita, that things had unified during COVID and now are perhaps unintentionally getting disparate again. Is that a correct reflection? Or
yes, so it was actually rather incredible during COVID how services in London, the ICBs kind of came to, what they used to be, kind of came together to provide a unified, simplified approach to allow us to get patients out of hospital where we knew the pressure on hospital beds was incredibly heightened during COVID, and also keeping other patients who did not have COVID safe and getting them home as soon as possible became a priority. That process was really simplified and unified across London, and that massively helped. And it's interesting to see that, it kind of shone a light that is a possibility.
Yeah, it's a story we hear quite often in relation to the COVID. Ruth, did you want to come in briefly? Oh.
Yeah, I'm conscious that we haven't mentioned the key changes that came in with the Health and Care Act, which I think they offer both challenges and opportunities. So the big change with the Health and Care Act was obviously the replacement of clinical commissioning groups with integrated care boards. There are 42 across England, of which 5 are in London. One of the opportunities, and what's happened is there's now less national direction of policy around health since that act came in, because the ICBs have more ability to make decisions locally, and they hold more of the spending locally as well. One of the good things that happened alongside the introduction of integrated care systems was that the Health and Care Act actually introduced this new legal duty for integrated care boards to commission palliative care services that are appropriate for meeting the needs of their local population. This was something that at Marie Curie we campaigned quite hard for, because when the bill first came into Parliament there was no mention of palliative care at all on the list of services that those new bodies would be required to commission. So we really welcomed the government of the time adding palliative care to that list of essential services. And that does provide an opportunity for decision makers like yourselves to ask ICBs, how are you doing on meeting your new statutory duty to provide palliative care services? I think they will probably honestly admit that they're doing their absolute best, but more work to be done. but it's an important opportunity to open up new discussions about the importance of palliative and end-of-life care that perhaps weren't possible under the previous arrangement.
Rebecca, so you've got your hand up, and I was also going to come to you next to ask about what the biggest challenge is about delivering end-of-life care and palliative care in your setting were. So perhaps if you want to do your addition to that.
Thank you. Yes, I was just going to echo what Ruth was just saying about the access to palliative care for all and how things have changed. And I have to say, so the hospice that I'm in is in southwest London, and our community, the only access that our community have to palliative care, support and advice at a weekend is through the hospice. There isn't anything through the NHS. And I think that's one of our frustrations, is that it's been talked about, but actually in reality it's not happening everywhere. It's very patchy, it's very inconsistent, and I think there needs to be some holding to account for that. Moving on to the hospice, if I can just give you a very, very sort of short summary of what hospices do, because I do think there are a lot of myths around hospices. So I think it's important just to highlight that we are very much community assets. Most of our patients are cared for at home, not in the hospice building. It is not just about the hospice inpatient unit. I think that's really important to highlight. The challenges that hospices are having is around funding. I can sort of talk on behalf of St Raphael's. We get around 25% of our funding from the ICB. The rest is charity funded. That's about, we have £6.5 million a year that it costs for us to run. 1.7 million comes from the ICB. The rest is down to us. And so last year we made £1 million worth of cuts, and that has meant that we had to cut our community services, which seems so counterintuitive when we're talking about supporting people at home. We had to cut our hospice at home team, which means we no longer have people going into the home to care for people at the end of life. We have our community team, our community specialist team, and they are the people that take those phone calls that we're talking about. They do those complex assessments. They advise GPs, they advise district nurses, they educate, they fill those gaps. But we've had to make cuts across all of our services, our medical services, our therapy services, our living well services. And I think, if we are going to address these issues and raise awareness, hospices, it's important that hospices are recognised not just as this small part of the puzzle. They're actually a really big part because of the education that we provide and the close working that we have with all of those community providers in both healthcare and social care.
Thanks. And obviously you just mentioned there massive cuts of £1 million last year, which would have had a massive effect on service. Do you know what the cost of national insurance increase would be to your work,
Yeah.
or is that?
That's impacting us £140,000 per year on top of the bills that we already have. And just to sort of put that into context, we've had this £100 million grant from the government, which we really welcome. It's been fantastic for us. But that's to be spent on digital services and capital projects. It's not to be spent on staffing. So that money that we are getting at St Raphael's will soon be wiped out by the £140,000 national insurance hike.
Thank you. And just one final question for me is, just kind of the same question to you on the major challenges within the hospital setting.
In terms of ICBs or just major challenges in the
Yeah, sorry, we did ICB, so just more widely. Or you can say ICBs, of course, and if that is it. But I wondered if there was anything else that you'd wanted to add.
Yes, so I suppose just staying on the point of ICBs, there's a couple of things that affects us kind of quite massively in hospitals. So I think, as Ruth had talked about, innovation in providing excellent palliative care is really important, as it is in all services we provide in healthcare. And I think there has to be funding and scope for us to innovate new and better services. And I'm going to give you an example from the Marsden where I work, that as you know, palliative care is not just end-of-life care. We are there to really support and help improve quality of life for all people with life-limiting illnesses anywhere along their disease trajectory where we are needed. So it's about getting to the right patient at the right time and providing the right care. One of the innovative services we have started in some of our tumour groups where we know symptom burden and complexity is very high is a trigger service where actually when patients are coming to see their oncologists, if they trigger on a list of kind of concerns, it automatically means that a palliative care specialist goes down to clinic and reviews them. And so we get involved at the right time and we're not picking up people when they're in the heap, you know, where everything's at crisis point. Now, that's a service that's been researched and shown to be very successful. We wanted to extend this service to our haematological cancer patients who also have very complex needs, and went to our local ICB for funding for this to trial this service. And the response was that if it's not cost saving or cost neutral, they couldn't underwrite or commission this service. And I think that I'm giving that example because that's made me kind of reflect on a kind of bigger issue, that we have to start to recognise that palliative care is not an add-on. You know, if this was anti-cancer treatment and endoscopy service, other hospital services, people would not be looking for cost saving or cost neutrality necessarily. They know that these are vital services. And I think we have to recognise that palliative care services are vital services. Nearly all of us will need to access them at some point in our life, whatever, you know, wherever we are in our, you know, NHS or health journeys. And I think we have to start to re-look at how we are looking at these services and how we're measuring outcomes when we're looking at what we're funding or what we're commissioning. So, you know, we already have really good kind of patient-reported outcome measures we use in palliative care. You know, we should be looking at things like that more rather than just looking at things like cost saving. And we need to really recognise that this is a vital specialty, as is everything else. And I think, you know, ICBs and other groups need to look at this when they are thinking about what they're commissioning. So I suppose that's my first thing to say. The other thing I wanted to say, I suppose going back to what Becca's been talking about, is that in hospitals we obviously see a direct knock-on from what's available in the community in terms of being able to discharge our patients safely home. And it's interesting because at the Brompton, where sometimes I have the most complex patients, so talking about patients with advanced motor neuron disease with very complex needs, or even patients which we have to send home with tracheostomies who have incredibly high care needs, ICBs are kind of incredibly good at providing that very high level of care and need for those, you know, very, very kind of complex patients, and we get very little pushback. But when we're talking about kind of our maybe more standard end-of-life patients who are choosing and wanting to go home to die, again, as I know a lot of the panel have said, you know, what we're finding is that the care and support that's available in the community is really patchy and has changed over the years. So, you know, really important services like district nurses, our community palliative care services where, you know, when I started in palliative care 15 years ago, actually hospice to home services where, you know, trained carers would go into the house to support people, and night sitters where, you know, would provide families with really important respite. All of these things that were widely available are all diminishing due to financial constraints, workforce constraints, and that's really having a knock-on effect. So for me, as a palliative care consultant, having those important discussions with my patients about what's important to them, what their wishes are, where they want to be, I sometimes feel that I cannot then, if they tell me that they want to be at home in their own environment and have a dignified and comfortable death, I cannot make that a reality. So I'm not really giving them a choice because, and as we've touched on again, if people have really good family support systems, if people have financial ability to top up their care, it makes it much more likely that they can get home and be cared for at home. But actually, when we look at our most vulnerable that don't have the financial stability, that don't have the family support networks, as we've heard in London, that's a significant proportion of our patients. And as we go into our elderly population, that increases even further. then actually we're not able to necessarily provide the level of care, the level of expertise, the level of support they need to go home and die at home. So that one means that sometimes they end up staying with us in hospital, which may not be their chosen place. And death and dying is not about hospitals and machines. It's about your community, your environment, your loved ones, all of those things. Or that we try and step them down to hospice for holistic care. And as you've heard, more pressure on hospice beds, more pressure on communities. So it really has a knock-on effect. And if you think about our hospitals and what we're there to do, actually it's not the best place to be caring for patients, even though I can tell you our teams provide excellent end-of-life care in hospital. It's not what the hospital beds were designed for if people are not complex and can be at home. Actually, the beds are designed for looking after, the acute, unwell, patients who need surgery, patients who need chemotherapy, patients who need hospital services. So it really puts a strain on getting people home and fulfilling their wishes. Can I just make one more point? Sorry. Going back to the ICBs as well, one of the things that was fed back from our complex discharge teams, again, when we're not looking at our end-of-life patients, but we're looking at our patients with palliative care needs, at the Marsden we find that, again, sometimes the communication is quite difficult. So cancer patients who may have had a prolonged stay in hospital and therefore, but are not nearing end of life, maybe, on their treatment journey and have, a year or longer to live ahead of them, they may actually need a reablement package to go home. So this is kind of, a kind of rehab package to allow people, it's a 6-week package to allow people to kind of get back on their feet once they get home, which is really, really important. So what our team have said they're finding is that ICBs are often just saying they're cancer patients, that means they're terminally ill, we won't offer reablement packages, even though our experts, occupational therapists and physios have assessed these patients as being rehabable and therefore eligible for this service. So again, there just needs to be that trust in professionals. And I know this all comes because budgets are getting smaller and everyone's, feeling that everything's tighter, but there has to be that understanding that actually, when we are speaking from hospital teams, we are assessing patients appropriately, and there needs to be a much more collaborative approach.
Thank you. Thank you. Assembly Member Wilson.
Thank you, Chair. Good afternoon, panel. So my first question, I think, is to Becca, please. And this is, I'd like to understand a bit more about how St Raphael's works with hospitals, community care providers, and local authorities to try and provide that kind of all-round sort of seamless transition for patients entering hospice care and receiving care from those sort of multiple sources, and how that all sort of fits together, please.
Sure. So the referrals come from GPs, hospitals, generally the acutes, and we will then triage them and work out whether or not they need specialist palliative care, in which case they would stay under our service, or whether they need generalist palliative care, and then we would refer them to the generalist teams in the community. We work very closely with the generalist palliative care teams, with the hospitals, with the GPs. We provide education and training for them. We'll do joint visits with them to make sure that that everybody is communicating to the patient at the same time and in the same way, if we're able to do that. But ultimately, we work very closely with the patients and their families to work out what is in their best interest, what is it that they really want, and then we will do our best to support that. Some of the frustrations, I suppose, that we have is around sometimes healthcare and the funding for healthcare provision at home. So we have to complete paperwork to request some carers to go into care for somebody at home, continuing healthcare fast-track paperwork, which is a 12-page document, which you can imagine how long that takes. then that goes off to the continuing healthcare team, who have a very tight budget, who will send it back and say, it's not quite filled out in the way that we want, we can't give you the money unless you can prove this, this and this. We do that, we go back. And so there are a lot of frustrations, I think, in working in those ways. But the appetite is definitely there. And I think we all really want to be able to work together to coordinate and make sure that we are streamlining services and we're not spending time in process when actually what we want to be doing is delivering that care to the patient at the right time. We meet regularly with our ICB, we meet regularly with the district nursing teams and so on to look at what those needs are. We have shared conversations every day with different teams to talk about our patients and say, is this somebody now that needs to move to your care? Is it something that we should be inputting? So I think there is very close collaboration, but I think in terms of the cuts that we've made, we're now having to be much more reactive. And unfortunately, what that means is even though our referrals are going up, our resource has gone down, and therefore patients are waiting for our services when actually, they shouldn't be having to do that. So we are not seeing them as early as we'd like to. We would like to be involved with their care much earlier and have those conversations about where do you want to be. But that's difficult, and I absolutely understand that all of the services are stretched, but I think what's very clear is we all want to do the same thing, but there's a lot of process in place that we could probably cut through and make more efficient if we were in a position where we were given that opportunity to get together and look at those particular areas of sort of bottlenecks.
Great, thank you. It's a very comprehensive overview there. Very helpful indeed. My next question then is to Dr. Salnow, and I'd like to explore sort of how you just describe the sort of experiences of patients and families when they're accessing palliative care and end-of-life care and so on. And in particular, I'd like to hear your thoughts on the role of unpaid carers and how we've had a written briefing from Carers UK, which I think sets out a lot of the challenges and the difficulties, but any kind of solutions or better support that those that are in that situation can receive to help smooth the overall process.
Thank you. So talking both from a clinical perspective, seeing patients at home, and also from some of the research that we're conducting, I think the first thing is to say that it is so complex to navigate, and we've heard a lot about this, the need to pull a much clearer pathway for people as they face the end of life. The first thing to say is if you have an unpaid family caregiver, someone, either a family or friend who's supporting you, then that already is a benefit, because we see an increase in the number of single-person households, and people without an advocate to navigate this system is even harder. But I see a great deal of people falling between the cracks, and I think the key things that we see, the red flag areas that need urgent attention are, one, around pain management. We know that many London boroughs don't have district nurse service available, so often it's the unpaid carers who are trying to support that, giving oral medication with advice over the phone. We've initiated a pilot service to train unpaid family caregivers to administer subcutaneous injections at home, because the district nurse call-out times are too long and people are dying in pain, waiting for more than 4 hours. So to overcome that, we've trained carers. Now that gives a huge benefit and skill to some people. It's very empowering. For other people, it's intimidating, and actually that's a step too far. But actually the reality of the system means that we're needing to work around that. The next one is trying to get medication availability, and many of the unpaid carers spend a great deal of time out of hours. I'll be writing a prescription, trying to get it to someone at 10 o'clock on the night, trying to find out where these medications are available. All ICBs have got pharmacies in the community who are meant to carry certain end-of-life drugs, but that doesn't happen, and those drugs run out. So availability of medication. And again, if you have a family caregiver, that's at least someone who can get out to get that. Often we see people who don't have anyone at home, and district nurses are not able to carry medication out of hours, etc. The next one is around equipment. We've heard a bit about that. There was a new tender, so NRS is the London provider for medical equipment that took over from Medicare. We have been in daily conversations with their chief exec around how difficult it is, how not only is it not timely, it's often in poor service. A lot of the people there have arrived, the technicians have said, I'm actually not trained enough to fit this, I can't put this bed together, I can't put this chair together, and big pieces of equipment left in people's living rooms. It's just really not good enough, and that's been raised, and we know that. but that I think is a huge barrier to dying well at home. And I think the final one is working in partnership with paid social carers, and that is a real challenge. So we know that to die well at home, you need to have support in terms of washing, dressing, eating, toileting, and also the kind of what we're increasingly calling death literacy, the kind of knowing what's normal when someone's breathing changes, knowing how to turn someone, knowing how to give them support around, mouth care, etc. And we know that people's death literacy in a community, and I include both paid and unpaid social carers, because I think they're the two parts of the same coin that we need to look at, have very poor death literacy. People are often very frightened, they don't know, they're often going back on when they cared for other family members many years before. And so how we improve the confidence to people providing that hands-on care at home, whether it's the family caregivers or the paid social carers, to allow them to know what's normal, when to call an ambulance and when not to call an ambulance. And so that idea of promoting the death literacy, really their confidence in their capacity to care for people in a hands-on way, is a real urgent priority.
Thank you. I think that echoes very closely the experiences that we've been through towards the end of last year with family members. So,
sorry, can
thank
I
you
just add that I think it's also really important to mention that actually community palliative care team and hospice teams really support family members as well as the patients, and I think that's what we don't see in a lot of other parts of the NHS or the healthcare system. We ask the questions, we make, even just being heard as a family member. And I think that's a really important part of what we do in palliative care. They're really part of that holistic care, and that's why it's so important that these community services are strong, because we're supporting the people who are supporting their loved ones.
Absolutely. Okay, and then my final question then is to Ruth, please. And this is, so what do you see as the main workforce pressures facing end-of-life care providers in London, and how does that impact on service delivery?
Thanks. So I'm probably stating the obvious, but workforce capacity just isn't sufficient to meet either current or future demand for palliative and end-of-life care. That's really, really clear. So in that survey that I mentioned of bereaved carers and their experience and the experience of the person who they love who had died, they reported really clearly that staff across health and social care settings don't have enough time to provide care for dying people. And the support that they did get was not available for as long or as frequently as they needed it. So there is a really big challenge in having the right workforce in place. As panellists have already mentioned, there are two parts of the workforce that need to work well for people at the end of life. One is the specialist palliative care experts, like those in Rebecca's service, and Libby's another example of that. I believe you are as well. Yeah. But it's important to recognise that only a small proportion of people will get access to specialist palliative care. And most people are actually getting their care from GPs and district nurses. And so there's challenges on both sides, and there are challenges around getting them to work really well together in integrated ways. So just to give you an example of the mismatch between the workforce and the rising demand, so the number of people needing palliative care has risen quite steeply in England in recent years, but so has the average number of patients that a GP is responsible for. So your average GP is now responsible for around 2,300 patients, and that's a 19% increase for them since 2015. So in about 8-9 years, they've had a giant increase in the number of patients that they're caring for. The GP shortages are particularly bad in the most deprived areas as well. The other thing I would draw your attention to is there's been a big decline in the district nursing numbers as well. So that's down 47% in England since 2009. So that's a massive decline in the number of district nurses. And I think both GPs and district nurses are really aware of, and they acknowledge the pressures that they're under. So the RCGP did a recent survey where GPs were honestly reporting over half of them said that they just don't have time to adequately assess and treat patients during appointments. 57% of them said that they just don't have time to build a proper patient relationship to be able to deliver really good quality care. And over 75% of those district and community nurses are reporting insufficient staff to be able to meet the needs and the dependencies of their patients. So challenges in specialist palliative care, because a lot of that's dependent on charitable funding, and that's very precarious, but also pressures in generalist services as well. The one thing I would say is there are some quite big things that could be done about this, some quite basic things that just aren't in place at the moment. So there is an NHS long-term workforce plan, but that doesn't look at all at the requirements of specialist palliative care. And it also doesn't look at the contribution that social care makes to that health workforce. So those are really big gaps, and the government has announced that it's going to develop a new workforce plan in the summer of this year. So we want that workforce plan to fully cover palliative and end-of-life care, and that means having a proper projection of both current and future demand. So what workforce is needed to look after these people, including both specialist and generalist palliative care. And it also means them having a properly funded plan in place for meeting that demand. That's not currently the case. There's also been some discussion in your earlier session about the training needs of the workforce, and I think that's really important to mention. Marie Curie, what we would like to see is recognition of the fact that every health and care worker at some point is going to be caring for someone who's going through dying or death or bereavement. And what we believe is that in both their initial training and in their continuing professional development, palliative and end-of-life care should be a compulsory component of both, so that when they have to look after people, when they will have increasing numbers of people with these needs coming through in the future, they'll feel confident and equipped to do a really good job there. So that's what we would like to see, to make sure the right workforce is in place. I also think it's really important to acknowledge the amazing work that health and care workers do in support of people at the end of life, despite not having enough of them and not feeling often like they have the right training. They do amazing work, and I wouldn't want any of this to take away from that amazing commitment that they show to their patients and to their families as well.
Thank you very much. Hopefully that can feed into the recommendations of our report or letter as we progress that.
Thank you. Next question is from me on the theme of inequalities. So I'm going to turn to Dr. Solno for this one. What extent is the unmet need of palliative care and end-of-life care in London, and are there any particular demographics or groups that are missing out on care?
Yes, so London is quite a polarised city, and so we see quite steep differences across multiple different demographics. I think the key thing is to say that social gradients exist across society in terms of education, finance, etc. And those same social gradients exist in end of life, in place of death, in experiences of grieving and caring. So those established gradients we really know. But the key to the two ones I'd really like to pull out is when we, with some work in Marie Curie, looked at putting the demographics across heat maps across the different boroughs of London. And that's really helpful to illustrate where you see the different patterns of changing. Now, we've heard a lot about poverty, and so that was one of the key things. Fuel poverty, deprivation really impacts the end of life and the ability to deliver good care. I can get a hospital bed delivered, not always, but when it is in place, we can get that into the home. But if I then turn up the next day and see often the bed is just being used as a shelf for pads, the cat sitting on it, and that's because people, as Catherine Buxton mentioned, have not been able to pay to have the electricity running 24 hours a day. So we see economic, specifically fuel poverty, but other elements of poverty is a key determinant of end-of-life care, and we see that very clearly in the capital. But what's interesting, if you put that on a heat map, then you'll see often the more central boroughs, the inner London boroughs, have higher indexes of deprivation, particularly when you look at older people. So the percentage of pensioners living in fuel poverty, that's very much concentrated around the central boroughs. But there are other parts where we're seeing unmet need and other demographic facts that really affect end-of-life care, and that's social isolation. Now, that doesn't come up as clearly on a lot of the indices around the key protected characteristics or key demographics that we know influence this. But actually, when you look at that on a heat map, it's the reverse. And so it's the outer boroughs where we have a larger number of people who may not be living in poverty, but older adults who are living alone, who do not have social carers, unpaid social carers, their families, to support them. And so we see this kind of inverse pattern as you move across the two models. And so I think what we need to look at when we're looking at unmet need is obviously the key factors, which are poverty and other factors around minority ethnic, certain groups, or ethnicity with an education. But the key one that cuts across all of those is poverty. But we cannot forget the reverse pattern that we see in London, which is around social isolation, and that is increasingly a really key part of enabling you to die well, because of all those factors of how you navigate the complexity of the service, and doing that while you're in your own bed is really impossible.
Just looking to sort of some of the ways that maybe that can be addressed. So what policies or initiatives should be prioritised in London to create a more supportive environment for people at the end of life, and particularly those groups that may be missing out on care?
So I think one of the key things is to recognise that this isn't just a health problem. And I think ICBs are great at beginning to look at how transport, how housing, how etc., all these other parts. So we need a cross-sector approach to manage this, because health can't manage the poverty that people are coming in with, and can't look at managing fuel bills, etc. So I think the key thing is looking at the role that housing plays. How can we support so our social workers, if someone's lucky to come into palliative care under our team, our social workers will work with energy companies to illustrate why they cannot pay. And certainly for certain groups who need oxygen running 24 hours a day, you are allowed to have electricity kind of subsidies. So I think we need to start looking much more clearly around end-of-life subsidies and how that fits in with things like special rules. And there's other clear patient groups that we've identified who may be eligible for something like this. I think one of the other things, at the moment, there's great inequity according to looking at support services. So often they are run through hospices, so befriending services, volunteer projects, community projects. They're very much piecemeal and depend on which hospice is around. We did have an initiative to try and run something across London to try and look at how these informal support networks can link to people who do have no one else at home, and how we can support with them. So I think how you can develop volunteer projects, volunteer services across London, so they're not just within isolated examples across ICBs or across boroughs. And I think the next thing really is understanding that complex interplay in the community and the role that social carers play, and how we ensure that they are skilled, compassionate, and able to manage the quite frightening situations that they're often there managed. So I'll let myself into a family's home with a key safe, go in, and we'll see a paid social carer trying to support someone who's incredibly unwell, often having breathing difficulties, and they often don't know what to do with that. And so at the moment, we know through Continuing Healthcare, CHC, there are private companies who are tendering for these care organisations, and we know that they have very, very little end-of-life care training, if any. And so there have been some systematic reviews, some scoping reviews, looking at what is the training delivered to these paid social carers who are on the Continuing Healthcare tender panel, and we know it's almost nothing. So I think what needs to happen across London is there needs to be a basic standard of what training is offered or mandated for all paid social carers who are on Continuing Healthcare panels, to ensure that they feel confident. They're a hugely vulnerable workforce alongside the people who they're caring for are hugely vulnerable. And so we need to look at that. And I spend a great deal of time, as do a lot of the other community services, is training training these carers informally in the community, saying this is what you would not need to call an ambulance for, this is normal dying. But there isn't that general sense. People are not seeing people at the end of life. It's quite fearful. So how we support that, I think, is a key policy step.
And just on that, so do you think that should be part of the tender process? Should it be something that
I think it should,
commissioners ask?
and I'd be interested to hear the other points of the panel, but I think it should absolutely be. It's shocking that people can turn up to care for people at the end of life and not have even basic training. I think it's essential.
Thank you. Thank you. Assembly Member Boff.
On that note, you talked earlier about advocates, about people who are not socialised, or I am concerned about those people who very much die alone without that advocate. You briefly mentioned that there was volunteer projects.
Yes.
Could you just expand a little bit on that and what is available to those people, many of whom have nobody else to speak up for them?
And I think this is a real public health issue. You know, social isolation is very clear. We know the health challenges of that. But at the end of life, it often really comes into sharp relief as you have no one to make a call, etc., or support you. So often through the hospice movement, there's a lot of projects that are building networks to support people. So we started something called Compassionate Neighbours, which is now running through 11 hospices in the southeast, many in London. And this trains local people. They go through a DBS check, so there's risk management, etc., but they're connected with people who are dying or caregiving in the community to allow them to be a bridge into either formal services, calling hospices, GPs, etc., or otherwise supporting them with collecting medication, understanding when they might need to phone a GP for some support. So many of these exist through hospices, because often that's the innovative part of end-of-life care, where hospices are coming up with new ideas. This is not something through the NHS. So I've spent many years working in hospices. Now I'm an NHS consultant. I've tried to start it. There's no way of doing that within the risk limited NHS services. So often they happen through hospices. So if you're lucky enough to live in a patch of a hospice, then you can often be linked through a service like this. If you're in Camden and Islington, where I'm practicing, there is no way of getting that service at the moment. So it's a challenge of how we can ensure that NHS services are also able to deliver volunteer community support for people who are isolated at the end of life, because it's very difficult to die well if you don't have that support.
And perhaps Ms. Trow might want to come in here. We're talking about hospices, but it is about also that advocate role, the person who can speak on behalf of that person, rather than just a befriending service.
And I guess that's the IMCA role, you know, having a formal advocate if you don't have capacity. So that's a kind of a separate role as well, which we support in the community. But it's the challenge when you fall between that. If you're still able to advocate for yourself, you still have capacity, but actually you're alone and you're unable to access services, make phone calls. And what we know is to kind of manage the complex system of end-of-life care in the community, it takes a huge amount of power, energy to phone, to go onto different helplines, and often people just don't have that ability if they're living by themselves and they're unwell.
Thank you. Ms. Trow, you must have a view on these services.
Yes, so we have the Compassionate Neighbours service as well, and it's a really beneficial service. We match our volunteers with patients with specific needs. So, for example, we had somebody recently who only spoke Bulgarian. We happened to have a Bulgarian volunteer that we could match and actually supported that person up until the time of death. So that was fantastic. I think that we rely hugely on volunteers, and I think it's an area that we can develop further. But there needs to be some resource behind that to be able to do that and provide that sort of training. I think it is partly befriending, but it's also about understanding, as you say, the sort of, you know, what might happen as somebody's approaching the end of life. You know, who do they need to contact? What sort of care might they need? We're actually looking at St Raphael's at the moment. We're exploring the possibility of a volunteer-led service that would provide something similar to that, but perhaps with a slightly higher level of clinical expertise through education. But what we would be doing potentially is asking for, depending on the family setup and the social setup, whether or not there's a donation that could come through that, because obviously that's another way of us supporting, you know, the hospice service. And it certainly wouldn't be, you know, you have to give us some money to be able to do that, but it is another income stream that we're looking at. I think it's it makes so much difference as well for carers if there is this sort of scheme, because it supports the carers, and very much they tell us very often that, you know, they have all of these services that come in while their loved one is unwell, and then the loved one dies and everybody goes and they're suddenly on their own, and then they have quite complex grief to deal with afterwards.
So if the person remaining is also socially
Yes,
isolated.
exactly. So
creates
we
an
developed a
issue,
role
yes.
when I was at Princess Alice Hospice called the Carer Companion, who would actually be matched with the carer and would support the carer for the time leading up to death and stay in contact for 3 to 6 months afterwards as a volunteer to be able to support that person. So I think there are all sorts of avenues to explore around volunteer services.
Yes, Dr.
I'll
Simon.
be very quick. Just to say that there's a lot of evidence, particularly from Europe and Canada, looking at the care navigator role. And that's something that often is a semi-professional role. So either they can be paid or they can be volunteer-led. And there's lots of studies looking at how that can be supportive in advanced cancer when you have a great deal of different pathways to manage. But I think it's understudied and underused in end-of-life care, because we're only just really beginning to recognise the complexity of the system and how you navigate it in the community is huge. So I think there could be something between a kind of supportive, compassionate neighbour volunteer role and someone with a bit more companion, like maybe your companion role, that would allow you to actually navigate and say, actually, I know how to advocate. Let's get through to that service now. Let's get you an appointment. But at the same time, they could support the carer after that person dies, and actually is that continuity. So I think something around a care navigator role and understanding that actually every Londoner at the end of life would need to be linked with a care navigator role would be a really key output. Who would fund that is a big question. But I think it would be a key, it would really help with also the complexity of the single point of access.
Can I just
Yes,
quickly say,
Dr.
just to
Jamal.
take a step back in this whole process, is, you know, as you've heard, there's lots that palliative care teams do to signpost, support, advocate for our patients, the most vulnerable of our patients. But actually, it's getting access to our services in the first place. And I think that's, you know, as we've heard from other people, you know, it's actually making sure that, you know, generalists in healthcare identifying dying, identifying palliative care needs and referring, because once they come to us, we are very good at providing that advocacy and support and finding ways and figuring out what's important to our patients and if they have fears about dying alone and how we can mitigate those things. But it's actually, you know, those people being able to access our services, and I think that's why, you know, the kind of platform for palliative care needs to be bigger, and people need to understand how important it is as a service.
Thank you very much. The Chair's not going to thank me for putting that last question in. We pushed us all right up to the limit. But as a final question, if possible, in 2016, the Health Committee wrote to the Mayor recommending a series of recommendations, but we did a review on end-of-life care beforehand. And those recommendations included championing the issue of end-of-life care at a local level, pushing health and well-being boards to include end-of-life care in their health and well-being strategies, and to incorporate the end-of-life care review into the health inequalities strategy of the Mayor. Do you think any progress has been made on that since 2016?
I'd say, unfortunately, limited. I mean, I've been trying to work with Camden Health and Wellbeing Board, and they're interested in having a conversation about death and dying, but I'd say there's very limited integration. And the inequalities, I think we have more evidence to inform that, but I'd say in terms of actual progress, there's been much less. The case is getting bigger, and it's a more well-informed case, but there's not been as much work as I think.
So do you think the Mayor could provide a role of either convening or as an advocate or anything? Sorry,
Yeah.
Ms. Driscoll. Ms. Driscoll.
Yeah, I think we all do agree. We actually had a discussion as we were waiting to come in, and I think we all agree that the Mayor has a very important role to play in convening all of the different players in the London system who need to improve access and quality and sustainability of palliative and end-of-life care. You would agree with that, wouldn't you? And I think there are also some quite concrete ways in which he could do that. So we would, at Marie Curie, we would like palliative care to be a strategic priority for the London Health Board, and we would like them to have an action plan to tackle inequalities in access to and experience of that care. We would like the Mayor to include palliative care in his health inequalities strategy, which was one of the recommendations that you made last time. We also think he could perhaps work with you as London Assembly members to have an end-of-life care champion for the next mayoral term who could try and coordinate action and take a visible leadership role in making all of this happen that we've asked for today. The other thing I would say is I think there would be particular value in the Mayor leading a discussion around the idea of 24/7 access as to this care in London. Terminal illness doesn't respect the clock. People get really unwell at nights and weekends and bank holidays, and you've heard a lot about their struggle to access medicines through community pharmacies, prescribers. You've heard a lot about them being able to get to the hospice but not being able to get the GP or the district nurses out, and just enormous potential to do better on the 24/7 side in London.
Can I just add that even in hospitals, not every hospital in London is able to provide face-to-face 24-hour palliative care specialist access, which is one of the government recommendations. So that's something that, you know, needs to happen so our patients have have access to specialist advice and care.
So the mayor has a job to do.
Yes.
Very good.
I think you all have a job to do.
Yeah, we all have. I was going to suggest myself as the end-of-life care advocate because I'm closest to. Anyway, back to Chair.
Thank you. Thank you, and thank you to our guests for all your contributions today. Can we note the report and today's discussion? Noted. Can we delegate authority to me as Chair in consultation with party group lead members to agree outputs from this discussion? And can we note the committee's work programme and the site visits that took place to King's College Hospital to visit their HIV service and Liverpool Street Station?
And especially the Liverpool Street. Well, no, the other one was good as well. But we actually learnt something from that. I now know what to do if I see somebody who's.
Yeah, so we've all
who's
taken
got
part
an
in
arrest.
lifesavers
Very
training, and yeah, it was a good visit. The date of the next meeting of the committee will be confirmed at the annual meeting of the London Assembly in May 2025. I have no urgent business, and I therefore declare this meeting to be closed.
Thank you. Can I know the meeting's closed, but can I